and I'm with AIM at Melanoma. I'm going to have the opportunity to talk to you more about our foundation later on. My role up here is a little housekeeping. So I'm sure you can tell from my voice that I'm from the South. And so the first thing I'm going to do in my most gentle Southern way is to ask you to make sure that your phones are muted. I appreciate that so much. The other thing that I want to do is, of course, I want to greet not just everyone that's in the room, but also the hundreds of people who are joining us via Zoom and Facebook and Live and X today. We have about 250 people that have signed up. So this, of course, is a symposium that has been well anticipated by those who follow AIM at Melanoma, and we're so glad that you're all here today. I want to thank Dr. Gimbel and all of our esteemed panelists for their presentations. I know that you are anxious to hear from them, as I am too, and that there will be questions. And so my real job up here is to explain how our question and answer period will work. We'll have 2 question and answer periods. If you've had a chance to look at your agendas, you will see that we'll first have 3 speakers and then a question and answer period, followed by a break, and then some more speakers, and then a final question and answer period. If you're here in the room, we have given you some note cards that are in your packet. We need you to write your questions down, and then we have 4 volunteers that are now going to raise their hands. Jacqueline and Adina and Tara, and okay, there we go. They're in the back of the room. You need only to raise your hand and let them know that you have a question, and they'll dash that up to Dr. Gimbel so that he can decide in what order he would like to answer your questions. But if you're joining us live, what we need you to do is, if you're joining us via Zoom, then we need you to look at the bottom of your screen and you'll see a comments tab, but also you will see a Q&A tab. And it's the Q&A tab that we need for you to put your questions into. If you are joining us via X or Facebook or YouTube Live, then if you will put your questions into the comments section, we will transfer them over to the Q&A session for Dr. Gimbel. And so with that, I'm going to pass the baton to our moderator, Dr. Gimbel, and he is going to get our symposium started. Thank you.
Thank you, Anne. We couldn't be happier to be partnering with AIM at Melanoma for the symposium today. We're really excited to have everybody here, as well as everybody online. This is a chance for us to kind of display some of the things that we do to a patient-facing group, which we don't get to do often. Most of the things that we do are to our colleagues, to other physicians. So it's nice for us to get these interactions with our patients and the community in general. So hopefully this will be very educational for you. Nuts and bolts, we tried to keep it in a way that wasn't too scientific, but enough that you can understand some of the topics and what we have to deal with. So we do have a great panel today. A lot of people who spent time to come here today to present to you today. I am a surgical oncologist. I'm going to be talking about the surgical management of melanoma. We have Dr. Jordan Abbott. She's an oncodermatologist who's going to be talking about genetics and melanoma. We have Dr. Fadi Mahmood. He's a medical oncologist, and he'll be talking about neoadjuvant treatment. If you don't know what that means, he'll explain all of that. We have Dr. Rina Sabo, and she's going to be discussing kind of dealing with the fear of recurrence of melanoma. And then we have Lillian Swatek. She's a registered dietitian, and she'll be going over some of the nutritional aspects as well as survivorship for melanoma. So it's for cancer in general, but I think it's a great panel that we put together. So we're really happy to do this. This is being recorded again, so please be cognizant of that. If there's any noises in the background, it will be picked up on the microphone. So just be aware that there are other people out there listening. So just please be aware. We are going to be having a photographer. So there is a photography disclaimer. If you are here, you've kind of agreed to say, hey, if I get put into a picture, I don't mind that. And we may not name you, but you may see your face in a picture. We do have food outside for those people who are here, and restrooms are to the hall to the left. If you do need to use it, just please go ahead and just try to limit the noise that you do. All right, so I'm going to introduce our first speaker today. Our first speaker is Dr. Jordan Abbott. As I said, she's an oncodermatologist here at Banner MD Anderson Cancer Center, and she specializes in the treatment of cutaneous malignancies, as well as the management of cutaneous side effects of our cancer therapies. She's going to be talking today about genetics and melanoma, so please welcome Dr. Jordan Abbott.
All right, thank you. So first off, I just want to ask how many people in this room have had genetic testing? Okay, a few. How many of you are unsure if you've had genetic testing? Okay, so I'm Jordan Abbott. I'm a dermatologist here at Banner MD Anderson, and I care for many patients with melanoma. I found that this is sometimes an area of confusion for my patients. Sometimes when I'm seeing them, I may recommend that they have genetic testing performed. And sometimes the patient may tell me, I think I've had that done already. I'm not quite sure. And so I'm hoping to dive in a little deeper today and clarify some of these concepts. Okay. All right, so we're going to start off by going back to 9th grade biology and covering some of the basics of genetics. So we know that the human body is composed of millions of cells. And within each of those cells of the body, you have your DNA, or an instruction manual that codes for all of the processes that go on within your body. So when we look in at the cell, we see this double helix structure, that's the DNA, and it's wound up into these structures called chromosomes, which are in every cell of the body. So what exactly is a gene? A gene is just a segment of DNA. It's just referring to a portion of the DNA that codes for something specific. So you could think about a gene for eye color. I like the analogy of a cookbook with lots of recipes in it. So a cookbook contains instructions for how to make many things. So that could be thought of like the DNA has the instructions for all the processes and proteins your body needs to make. And a recipe is the instruction for something specific. So that's going to be like the gene that's coding for something specific. So if we have a normal, healthy gene, we're going to expect that that's going to result in a good, normal protein product. And if the gene is defective or has a mutation, it may result in an abnormal protein or no protein at all. So going back to our analogy, if you have a good recipe that you're able to follow the instructions, hopefully, if you're a good cook, you'll get a good product that you're expecting to get. However, if you have a recipe that maybe got a little water on it, you can't read the instructions so clearly, now you don't have a guarantee that your product is going to be what you desired. Okay, so now we're going to talk about cancer. What even is cancer? So we talked about all of those cells that are all over the body. Normally, those cells go through a process of replication and cell division to make our normal healthy tissues. Cancer is when this process gets disturbed and one of those normal cells has some DNA or genetic damage, and it continues to replicate and then produces this mass of cells, or what we call a tumor, and that is cancer. So if we look at this cross section of the skin, we have some healthy, normal skin tissue on top, and then we can see that reddish brown tumor, which could be a melanoma. So throughout an individual's life, we're exposed to many things in our environment, like UV rays from the sun, and some lifestyle factors that do influence a person's chance of developing cancer. On a cellular level, this is happening when these environmental or lifestyle insults are coming in and actually breaking or changing the DNA. So when we think about cancer and DNA damage or mutations that happen, there's really two different types. If we look on the left, we can talk about somatic mutations. So at the top of the diagram, we see a healthy sperm and an egg that are coming together to make an individual. And we have a person who throughout life is exposed to some things in their environment that cause some DNA damage. So here we see the sun's rays just causing localized. The diagram is showing this red area where there's localized damage. Notice it's not affecting all the cells of the body and has no potential to be passed on to the children. However, on the right side, we see what's called a germline mutation, and there the sperm actually has the mutation in it. So now all the cells of the developing person are going to contain this mutation. And since it is affecting all the cells of their body, it does have the potential to be passed on to offspring. So this relates to cancer in that most cancers are what we call a sporadic cancer. They're due to those environmental lifestyle factors as well as age. And that's where we have a DNA damage that occurs and it's just affecting a localized area. Versus in a hereditary cancer, we're talking about an inherited risk factor or inherited mutation. And this does put individuals at a higher risk for developing cancer. So when we talk about gene analysis or genetic testing or molecular biomarkers, there's a lot of terms that can be thrown out, and there's multiple ways that those are relevant for melanoma, so we're going to jump into those. So first off is going to be personal genome testing. We know that the vast majority of melanoma is due to those lifestyle and environmental factors that we discussed earlier, about 90%. However, there are 10% of cases of melanoma that are thought to be due to an inherited gene mutation or a risk factor that's putting someone at risk for developing melanoma. So we call this hereditary melanoma or familial melanoma. And again, this is only about 10% of cases. And this is when someone is inheriting a mutated gene that puts them at increased risk of developing melanoma. People who have this genetic mutation are thought to have about a 60 to 90% lifetime risk of developing melanoma, depending on which gene it is that they have mutated. And at the bottom, you'll see some of the implicated genes. And so here we're talking about this germline type of mutation. So someone inherited this from birth. It affects all the cells of their body, and they do have the potential to pass it on to their offspring. So who are the people who should consider genetic testing? Your physician may recommend genetic testing for you if you've had 3 primary melanomas. So that means 3 separate melanomas on your body that were completely unrelated to one another. Or if you have a family history with 2 or more relatives that have had melanoma or pancreatic cancer. And then if you have had a family member who's actually had this type of testing and they were testing positive, then you may want to have the testing yourself. And why would someone want to have this type of testing, or how to have this type of testing? So you have this, your physician would usually recommend this for you, or if you asked about it and you're a good candidate for the testing, you'll be referred to a genetic counselor. The test is usually a saliva or a blood sample, and it gets sent out, and the report will do an analysis of those genes that are most often implicated in these hereditary or familial melanomas and report back if there's a change in those genes that could be putting you at an increased risk. And why would someone want to have this done? So this can really influence lifestyle choices that someone makes. My patients who are known to have these types of predispositions are much more vigilant about skin protection. It's also helpful for determining screening frequency. So most people who have found out that they have this type of predisposition will be seeing a dermatologist regularly for full body skin exams. And it's important to remember that a positive test does not necessarily mean that you will develop cancer. It's just talking about your risk for cancer. So maybe some of you have tested positive for a genetic mutation. What can you do with that information? So that mutation informs your risk of developing melanoma depending on which gene it was. It also can tell you if you are at risk for other types of cancer. And that can help with screening guidelines if you need to have your skin checked at a regular interval, and then also any other types of cancer, such as pancreatic cancer. This can also be helpful for informing family members that they may be at risk. And sometimes family members decline testing and they don't want to have testing themselves, but they should still be appropriately screened. Okay, so now we're going to move over into another way that gene analysis can be relevant to melanoma. So here we're going to be talking about the somatic type mutation. So this is now focused on isolated DNA damage that has occurred, and it's not at all areas of the body. It cannot be passed on to offspring. So as a dermatologist, when I am evaluating someone's skin, I am seeing many lesions that look like this. This is a benign, healthy mole. This is a spot that we do not need to do anything about. No intervention is required. However, sometimes when I'm examining someone's skin, I may see a lesion that looks like this, and this one is very concerning. There are multiple colors. It has an irregular border. I'd be very concerned that this is malignant and recommend a biopsy for my patient. However, for dermatologists, we often encounter these challenging lesions that are more indeterminate. They are not clearly benign, but they're also not clearly malignant. And that poses a challenge. What do we do with these? So your physician may discuss with you. We could go ahead and do a biopsy. We could monitor with serial photography and dermatoscopic photography and see if there's any changes. But there's a relatively new technology called a pigmented lesion assay. And so this is a little patch. So it's a way to non-invasively test. And it looks at the genes just on that top layer of the skin of that mole to determine if the gene expression is more consistent with a benign mole or with a melanoma. So it's pretty easy to perform this type of testing. You identify the lesion that's suspicious, you apply that adhesive patch and send it out, and the results that you get back can help to guide the next steps. It's going to be really helpful if a patient is reluctant to have a biopsy. You would get these results back that tell you if the genes that were expressed there are more consistent with a benign lesion or something that could be melanoma. One of the benefits of this technology is that there's really no specialized training required. So this could be really utilized for primary care physicians who may not have as much experience with pigmented lesion analysis. Another way that genes or gene analysis can be related to melanoma is with the actual testing of the melanoma tumor. So again, we're talking about these somatic type mutations, and we can look at this for both prognosis and treatment of melanoma. So when we're thinking about prognosis for melanoma, we can go back to the biopsy specimen of when you had the melanoma diagnosed. And when they reported on the biopsy, they looked at many things. They looked at the depth of the melanoma. They described some characteristics of it. But we can take that same tissue and run a test on it that's looking at the genes that are expressed. And based on those genes, determine independently of the depth and other visual features that were seen under the microscope, what is the risk for recurrence or metastasis? And this type of testing can be helpful for determining if you're going to do lymph node testing at the time of the excision of the melanoma. So this is just an example of a report. This stratifies patients into classes of low, intermediate, or high risk for having a recurrence and can be helpful for determining those decisions about lymph node biopsy. So we can also look at genes when it comes to treatment for melanoma. So this is a little bit of a busy slide, but we see on the left that brown melanoma cell and on the top right, that blue T cell. Many of you have probably heard of the term immunotherapy, and immunotherapy is really the concept of activating our own immune system to fight the cancer. So normally our immune system fights off foreign invaders. Like if you had a virus in your body, your immune system should be fighting it off. Well, your immune system should be fighting off cancer too. That is foreign and it's something your body doesn't want. But sometimes your immune system is not responding fully. So immunotherapy is a way to stimulate that blue T cell to then fight the melanoma cell that's next to it. On the other hand, there's this type of therapy called targeted therapy, where we're actually targeting the melanoma itself. So as you see, there's this little pathway that's displayed within the melanoma cell, and all the cells of our body have these pathways that they go through. So we can do genetic testing that's looking to see if someone has a mutation in somewhere in this pathway. Not everyone with melanoma is going to have a mutation in this pathway, but if they do, we can target it with some targeted therapies. And so that's the term targeted therapy that you may have heard, is when we can actually target this melanoma cell from replicating and dividing and proliferating. Okay, and the last way that we're going to talk about gene analysis in melanoma is for DNA testing for surveillance. So this circulating tumor DNA testing is sometimes referred to as a liquid biopsy. This is a test that can be performed from the blood. It's a blood sample. And the idea here is that the melanoma that maybe is on someone's arm is, as that melanoma is growing or decreasing in size, as it's changing, it's releasing little fragments of DNA out into the circulation. And if we remember, the DNA in that melanoma is going to be different than the healthy, normal DNA of all the other tissues of your body. So that DNA is not going to exactly match the normal DNA that's in your blood. So we can test the blood to see if we're finding any fragments of DNA that are representative of that tumor. And this can be really helpful for detecting relapse in someone who's in remission, or for monitoring response to treatment in someone as they're starting and going on their therapy. So in summary, we talked about a lot of ways that genetics or gene analysis can be related to melanoma. The first type that we talked about for the hereditary melanoma is the one that is the inherited risk factor and that can be passed on. All of the other ways that we talked about are really looking at the tumor itself to look at the genes, and that can influence the testing for melanoma as well as the treatment decisions and surveillance. All right. Thank you for your attention.
All right, that was great. Thank you very much. A really comprehensive overview of things that we all question and wonder, and I still have a lot more questions now, and I'm sure we'll get some afterwards in the question and answer session. So please make sure if you do have questions, fill out your cards, or online, please submit your questions in the comment section. All right, so as I introduced myself before, my name is Mark Gimbel. I'm a surgical oncologist, and I'm actually the medical director of the T.W. Lewis Melanoma Center of Excellence here at Banner MD Anderson Cancer Center. And this center has allowed us to offer this partnership with AIM at Melanoma and a lot of the work that we do here at the Cancer Center. So I'm excited today to present to you the surgical management of melanoma. For those patients who are of mine that are in here, you've probably heard me tell you this story when you came to see me, or this talk when you came to see me. Same for those online. But if not, I think this is a good overview of how I manage a patient who comes in to see me and we're considering surgery for melanoma. This is my disclosures. So essentially, the management for melanoma is based on the stage of the tumor. If we're going to consider surgery, that's typically on the earlier stages, stage 1 and stage 2, where the tumors are confined to the body. Stage 1, they're small and localized. Stage 2, they're a little bit thicker, but still localized. Then stage 3 and 4 are considered more disseminated. The cancer has traveled through the body to other areas. For stage 3, it's traveled to the lymph nodes. And stage 4, it's traveled beyond the lymph nodes, whether that's the lung, the brain, the liver, just another area. But for the surgical management of melanoma, it's the early stages. It's typically stage 1 or stage 2. And we defined stage of melanoma based on how deep in the skin it grows. So in our skin, we have what are called the skin stem cells, if you will. They're the squamous cells, the basal cells, and the melanocytes, and all these can form cancer. And many of you may have had squamous cell carcinoma or basal cell carcinoma. Those are skin cancers, but not nearly as severe as the melanoma. And all these stem cells are in the epidermis. Over a lifetime, you get these you develop these mutations from all these environmental factors. If you have a somatic tumor, and the cells in the epidermis start to mutate, and they can form cancer. Well, if the melanocytes mutate, they form melanoma. And if it stays in the epidermis, that's called melanoma in situ. And by definition, a melanoma in situ cannot spread because it stays in the epidermis. But as the melanoma cells start to invade into the dermis, we're now talking about an invasive melanoma. And that's where surgery becomes a little bit more needed. And we also have to worry about risk of spread. And that risk of spread starts increasing as the tumor grows down into the skin. So I always have to assess for risk of spread. Now, the only way to identify how deep in the skin the melanoma grows is by doing a biopsy. So someone who has a suspicious pigmented lesion, they would see Dr. Abbott. She would say, yep, let's do a biopsy. We're not going to do that PLA. We're not going to do the patch. We're going to biopsy, take it out, and we're going to see how far into the skin this melanoma goes. And now once we know how deep it goes, now we're going to figure out what to do. So just to review this, the earlier stages, stage 1 and 2, you can see that I have these T1A, 1B. T means tumor thickness, and we can discriminate or at least measure how deep in the skin it goes to decide what stage. Early stage is going to, or stage 1 is going to be between roughly 0.2 and 2 millimeters in depth into the skin, and stage 2 will be 2 and beyond. For anything deeper, even a 10 millimeter melanoma, if it's localized, is still considered a stage 2 melanoma. The reason this is important for those tumors that are less than 0.8 millimeters in depth in the skin, typically the risk is so low that we don't worry about spread, that we cut them off. And if they're clear, there's no further melanoma, I would send that patient back to the dermatologist for continued surveillance. But once it goes beyond that 0.8 millimeter depth, the risk increases as spread. And now we're going to start assessing for spread. I got to start doing further things to make sure that the cancer hasn't spread. And so we know that the deeper it goes, that risk increases. So how do I assess for spread? Well, the way I assess for spread, we really have to think of how does melanoma spread? Typically, the way melanoma spreads, it spreads through the skin. It's a skin tumor and it spreads through lymphatics. And lymphatics are fluid channels that run all throughout your skin and drain the lymph nodes. So when we talk about spread of melanoma, we're really trying to assess if there's cancer in the lymph nodes. Now, when melanoma spreads to the lymph nodes, there's specific areas in the body where those skin lymph nodes are. There's essentially 3 regions that we have to be concerned about. For patients who have melanomas on the head and neck, the lymph nodes that the melanoma can spread to are typically up here along the jugular or the carotid. For those patients who have melanomas on their upper torso or the arm, the lymph nodes are going to be in the armpit, the axilla. And for those patients who have melanoma on the lower extremities and the torso, or in the lower torso or the extremities, the lymph nodes are in the groin. So it really depends where on the body the melanoma is going to predict where I have to assess for lymph node spread. One caveat to that is for patients who do have these thick melanomas that are greater than 4 millimeters in depth. If we go back to this picture here, that would be the all the way on the right side. You can see as the melanoma grows down, sometimes it can bypass the lymphatics and it can get into the bloodstream. It can go deeper. And then we have what's called hematogenous spread, not lymphatic spread, meaning it can get into the blood. And so for patients who have thick melanomas greater than 4 millimeters, I would actually get a scan ahead of time before any surgical intervention to make sure it's not someplace else. So, and if there is no evidence of disease on that scan, then we're still talking with stage 1 or stage 2 melanoma. And that's how I would define the pathway that the patient would need to undergo. Now we look at the spread. I've got to also consider, yes, it spreads to the lymph nodes, but when we're talking about lymph nodes in these certain regions, people have many, many lymph nodes in each of the regions. But when melanoma spreads, it doesn't spread to all of the lymph nodes equally. It'll typically spread to 1 or 2 lymph nodes first, and we call those the sentinel lymph nodes. So I don't need to assess all of the lymph nodes. So let's take, for example, a melanoma on the arm. If it's going to spread, it'll typically spread to the lymph nodes in the armpit. Well, in our armpit, we can have 20 to 40 lymph nodes, but the melanoma is not going to go to all of them equally. It'll go to 1 or 2 lymph nodes first, and we call those the sentinel lymph nodes. So many of you are aware of the concept of a sentinel lymph node biopsy. And what that means is I take out that first draining lymph node to see if there's cancer in it. If there's no cancer in that first draining lymph node, well, there's not going to be cancer afterwards. A lot of people will come to me and say, well, I want to scan. I've got a 1.5 millimeter melanoma. I want you to scan me to make sure it's no place else. No, that's not really the right thing to do, because when melanoma spreads, it typically spreads microscopically. We're looking for microscopic disease that's not seen on a scan. It's seen in the lymph node, and that's why I would take the lymph node out to see if there's cancer in it, but we're not going to see it on a scan, and I don't need to give my patients the added radiation just from getting CT scans if we know they have localized disease. And let me just move forward through that. Now, the only caveat here is if somebody comes in, and this isn't that uncommon, where they say, oh, I've got a little golf ball in my armpit, don't know where that came from. And lo and behold, they end up actually they find a primary melanoma, and the melanoma is already spread to the lymph node. This is called palpable or clinical disease. This isn't something I'd be looking for microscopic disease, because we already know that somebody has that melanoma in the lymph nodes. And once we know it's in the lymph nodes, now I am going to scan somebody to make sure it's no place else, because I don't want to miss having tumor someplace else, and I don't want to operate on somebody for regional disease if it's going to be in another area, and me operating isn't going to offer any benefit at all. If there is no distant disease and somebody who has a palpable lymph node or a clinically evident lymph node, then we would actually remove all the lymph nodes. I'm not just going to take out that one, we're going to take out all the lymph nodes, because we know that if you have disease in one that's significant, you could have disease in others, and we don't want to leave cancer behind. Before we go to the operating room, we actually will treat patients with treatments or therapies before surgery. We call that neoadjuvant treatment, and Dr. Mahmood is going to talk about this in a little bit, so I don't want to get in too much of the into the weeds here. So he'll be giving a lot of details on that. So, as I said, let's go back to the example of the melanoma on the arm. It's going to spread to the lymph nodes in the armpit. And I told you there could be 20 to 40, but how do I find the lymph node? How do I know where that sentinel lymph node is? Can't feel it. I'm not going to be able to see it. So the way we actually localize the lymph node is using nuclear medicine. Around the melanoma biopsy site, you come in and you get injected with a radioactive tracer. And that tracer gets put around the biopsy or around the melanoma, and it gets taken up into the skin lymphatics, and it'll drain to that same lymph node that if the cancer is going to spread to, that would be the lymph node it's going to spread to. So what this is going to look like is something like this. So this is a patient who has a melanoma on their back. A little off to the left side, you can see there on the top left picture, that center dark spot is the injection site around the melanoma. And then you can kind of make out that this is a person. You can see the arms off to the side, and off to the right side of the picture, the patient's left side. You can see another spot that shows up, and that's the draining lymph node. That's the first draining lymph node, the sentinel lymph node. And if you look at the top right square, you can actually see that lymphatic that shows up where that lymph node is draining. So we know that that's the first draining lymph node. And if the melanoma is going to spread, that's the lymph node it's going to spread to. So I need to take that lymph node out. I'm taking it out not because there's cancer in it. I'm taking it out to make sure there's no cancer in it. We want to look at it and say, no cancer in that. You're clean. We know your cancer hasn't spread. You have early stage disease. Same thing goes for the legs. So this is a patient who has a melanoma on their leg. You can see just at the cutoff of the bottom of the screen, there's a big dark spot. That's the melanoma. And you can start to see the lymphatics as they head up to the lymph nodes in the groin. And these are the two draining lymph nodes, one or two. Sometimes there's more, just depending on how the lymphatics go, that are the draining lymph nodes and are the sentinel lymph nodes. And these would be the ones I would need to assess. Another example here, you can see a nice lymphatic heading straight up the leg into that first draining lymph node. Now, two show up here, but you can see it's very linear. So I only need to take that first draining lymph node in the leg, because if it's not in that first one, well, there's not going to be cancer in the second one. So these images really help me predict or determine what I need to do in the operating room. And to take these lymph nodes out, we do have to go to the operating room. Things aren't always easy, though. Body doesn't always do what you want it to do. Someone who has a melanoma right in the middle of their back, well, the body typically is lateralized. Things on the right go to the right. Things on the left go to the left. Things up go up, and things down go down. But what if you got one right in the middle? This is an example of someone who has one in the middle of their back, and it actually could potentially spread to both sides. Again, just because these lymph nodes show up here does not mean there's cancer there. It's the potential for spread. But I would need to check a lymph node in both armpits to make sure there's no cancer there. I've actually had somebody who had a lymph node right smack in the center of their chest or in their torso, and they've actually spread to all four. And so I would need to do an incision in both groins and do an incision in both armpits to make sure. Now, that's based on the risk of their tumor. Someone who has a thin tumor, I'm not going to do that to. But someone who has a 3 millimeter tumor that's at high risk of spread, I'm going to say we should probably assess all four regions. The incisions are small, but they're still incisions. And that's a little bit harder pill to swallow for my patients, but I've got to give the data and say why we're doing what we're doing. So now I know where these lymph nodes are based on these images. Then we go to the operating room. Now, it's great that I've got this here, but if I'm going to make a skin incision, how am I going to find the lymph node based on this picture here? I'm not going to know where that lymph node is. So in the operating room, I actually use a device called a neoprobe. A neoprobe is essentially a gamma detector. It's a wand that I use, and I can put it into the nodal basin, and it picks up radiation, and it beeps. So if I have out here, I'm not going to hear any beeping. The closer I get to the actual lymph node with the radioactivity, it beeps really loud. So I have these auditory cues that I can find it, and I can hone in right on the lymph node and take it out, and we make sure of it. Not only do I use radioactivity, but when the patients are asleep, I then inject around that same melanoma with a blue dye. And that blue dye gets taken up into the same lymphatics and turns the lymph nodes blue. So if any of you have read your pathology report or looked at my pathology report on your specimen, you will see that there's a number, that's the radioactive number, and the level of blue. And that's just for characterization of the lymph node for the pathologist to see. But using the auditory with the radioactivity and the blue for the visual, it increases the sensitivity of getting that correct lymph node. And that's what we want to do. We want to make sure that if I'm taking a lymph node out, it's the right lymph node. And this is the way to do it. So if there's no cancer in the lymph node, again, stage 1, stage 2, early stage. If there is cancer in the lymph node, now we're at least stage 3. And if we've shown that it's stage 3, we've got to rule out stage 4. So that's how I assess for lymph node, but that's only the first part of it. The next thing I need to do is now excise the melanoma. Right? We know that if the biopsy was done, and even if all the margins were clear on the biopsy, if we don't do more to the melanoma, there's a higher risk that melanoma could come back. And we don't want melanoma to come back locally. We don't want it to come back someplace else. So I need to perform what's called a wide local excision. And that just means I'm taking a margin of normal tissue around the actual melanoma. The studies have shown that if you go narrow around a melanoma and just excise it without enough tissue, that it is going to come back, or it's at higher risk of coming back. So we're trying to lower that risk. And that risk is based on how deep in the skin the tumor grows. The deeper it grows in the skin, the wider it can be, on the outside of the skin, on the peripheral aspects of the biopsy. So that's why deeper melanomas require bigger excisions. Thinner melanomas do require smaller excisions. But for a thin melanoma, that's up to 1 millimeter in depth, I need 1 centimeter of normal tissue around there, and that's going to give something about the size of a $50. For a melanoma that's greater than 2 millimeters, I'm going to need a 2 centimeter margin, and that's going to give something about the size of a silver dollar. And I don't just take the skin, I take the skin and the fat below it. I take it down to the muscle. I don't take any muscle, but I elevate that off the muscle beneath. And now you can imagine I've got this big cavity somewhere in your body, wherever it's going to be. Now, how do I get that closed? Well, geometrically, closing a circle is not easy to do. It's going to be elevated edges. It's just going to be hard, a lot of tension. So this is where the wide excision comes. You can see that in the middle of the, on the picture in the middle, you can see the small dotted circle. But first you have the tumor in the middle. There's a circle around it. That's the margin that's been measured out. And then we ellipse the skin to make it easier to close. So that's why people get these long linear incisions on the arm for their melanoma. So for a 1 centimeter margin, it's about a 3-inch incision. And for a 2 centimeter margin, it's about a 5 to 6 inch incision. And that can be pretty significant, especially on some parts of the body. Imagine having someone in your lower leg. I'm not going to be able to close something that big on the lower leg because there's not extra skin. That's where I may have to get plastic surgery involved, doing skin grafts or even flaps. This is a patient of mine here that I recently had, and this is the incision that I needed to do on it. So you can see in the middle of his back, that small oval, that's actually the melanoma. I've measured out a 2 centimeter margin around this, and then I've ellipsed it based on his skin lines and where the least amount of tension is. I also show this because he has a tattoo. Tattoos don't care where your melanoma are. Melanoma doesn't care where your tattoos are. Let's put it that way. And while I try to make it look as good as possible, I really ruin a lot of people's tattoos. Some I can make look okay. This eagle lost a foot and a wing, and there was nothing I could do about it. So, but I am cognizant. Sometimes if they're linear things, I can try to make it look a little bit better. So that's removing the melanoma. We've talked about removing the lymph nodes, looking for spread, and that's for stage 1 and 2. Once we know you're clear, patients go into observation. Again, if cancer is in the lymph node, we're now talking about stage 3 melanoma. Again, if we identify stage 3, we need to make sure it's not stage 4. So then we do scans. We do PET scans, CT scans. Sometimes we'll even do MRIs of the brain to make sure there's no disease that's hiding in the brain that we can't see. Now, we do operate on patients who have stage 3 disease. That's been well established. It's changing with some of the newer treatments, but we're still operating on these patients. But a lot of the surgery that I do depends on the amount of tumor in the lymph node that I take out. If there's microscopic disease in that lymph node, and usually that means less than 1 millimeter, there's a lot of times where we don't have to do any further surgery. Just taking out that lymph node could be curative. And then there's a question of whether or not the patient needs treatment afterwards. Because once, as I said before, it gets into the lymph nodes, we're now talking something that's in the system. And maybe you need systemic treatment to help prevent it from coming back. When it's just microscopic disease, there's risks and benefits, and that's a decision that patients have with Dr. Mahmood to decide whether or not it's worthwhile to undergo that treatment. If there's macroscopic disease, and usually we say that's more than 5 millimeters within a lymph node, well, now there's a higher risk that this melanoma can come back and spread, and then we would recommend treatment after surgery. And if we talk about treatment after surgery, that's called adjuvant. We talk about it before surgery, that's called neoadjuvant. So we would consider adjuvant therapy. And then if somebody has a clinic, we know that big node that we talked about before, well, then we're going to remove all the lymph nodes to make sure it's not another lymph nodes. And these patients would be considered even for neoadjuvant treatment. I'm going to jump over this real quick. But I do want to talk about for stage 4 melanoma. Stage 4 is when melanoma has spread throughout the body, and people said, well, why can't we cut it out? Isn't this a surgical? Can't we just take out melanoma even when it's someplace else? Well, we have to understand what stage 4 means. Stage 4 means it truly is in your system. And me taking out a melanoma here, when we know it could be other places, that doesn't really give any survival benefit. And so I don't want to put somebody through a surgery that they're not going to have any benefit from doing, except for me giving them a scar. So I need to make sure that the patients are actually going to derive some benefit from me doing what I'm going to do. So yes, there is still a role for surgery in stage 4 melanoma, but it's limited, okay? If somebody has small volume disease, we see a lot of times that melanoma can drop itself onto the skin someplace else or into the soft tissue someplace else, and it can grow, and it can be painful, or it can just be the only site of disease. And if it's the only site of disease, then maybe there is a benefit of actually removing that and rendering a patient cancer-free. Another benefit of taking out a stage 4 melanoma is to see if they're responding to treatment. So if someone's been on treatment and it hasn't really changed, but when you take it out, you can actually see that the entire thing is dead. And we can say, wow, treatment's worked. Doing great, let's stay the treatment. Or if it's still a lot of disease, maybe we have to change treatment, and it can help direct therapy. We also use it for symptoms. I'd like to say that when cancer spreads, we can just take care of it, but sometimes we can't. And sometimes it lands in places that do cause symptoms. I see a good amount of melanoma that spreads to the intestines, that can cause bowel obstructions, can cause bleeding. So there would be a benefit for me to go in to remove that portion of the intestine that has the metastatic lesion there, to allow the patient to get over that and to continue on, especially if it's a bowel obstruction, to start eating again and moving their bowels. Tumors can also be painful. That's a lot of what we see. If they're in the armpit, they're someplace else on the chest, and we remove them for symptom control. And so we would need to have a good discussion of what we're looking at for our outcomes. But if it really will help with symptoms for someone who has spread of disease, then I have no problem removing a stage 4 tumor. Finally, there's areas where we can operate. The brain, the lung, the liver. Are we going to put somebody through a big surgery for that? Probably not if they have stage 4 disease, but we can consider radiation. And radiation can be focused to that tumor that can control that disease and hopefully reduce some of the symptoms as well. Now, one of the benefits of coming here for treatment, I got to give us a little plug, is that we do everything in a multidisciplinary fashion. You don't just see one doctor here, you see multiple doctors here, but you don't have to see them at the same time. Like if someone comes to see me and I have issues, or not issues, but I see that there's a complex case, we can bring it to a tumor board. And the tumor board is where we're all together. We've got the medical oncologist, the radiation oncologist, surgeons, we've got pathologists, radiologists, and our genetic counselors there. We can all discuss these challenging cases about the best way to manage. And so if you see one of us, sometimes you're seeing all of us. And it's a really great benefit to the patient to say, hey, we're giving you multidisciplinary care, and we can actually individualize your treatment plan. You've been through 3 lines of therapy. Let's look at the genetics of your tumor. What else can we offer? Can we do injectables? There's lots of other things that we can discuss and develop a plan. Sometimes it's straightforward and we don't need to take it to tumor board, but a lot of times having this at our disposal really helps us to make decisions and helps you as the patient. And it's important to be able to individualize that treatment plan. Then we also talk about surveillance and follow-up. Coming here means maybe you don't need to see me, the surgeon, anymore. You've graduated from your surgery, and now what's next? Well, we could do survivorship. We can do dermatology. Maybe there's other things that a surgeon may not need, or if you do need me, I can continue to follow you as well. So we have a lot of other options. Dr. Abbott talked about doing some genetic testing of the tumor, and that can help predict risk of recurrence. And so we can do those tests and look to see what kind of surveillance plan should we have. And ultimately, when it comes to those patients who are even the most challenging, they're not responding to treatment and who have spread of disease, we can also consider clinical trials. So hopefully I've given you a nice background of the surgical management. Most of the surgery is going to be for early stage. We do some for later stage, but at the end, after we're done with Dr. Mahmood, we will take some questions. And I do want to introduce Dr. Fadi Mahmood. Dr. Fadi Mahmood is a medical oncologist extraordinaire here at our cancer center. He takes care of so many of our patients, and I'd like to just thank him for being my partner in crime and want to introduce him for coming up.
Thank you. Thank you for the organizers. Thank you for AIM at Melanoma for giving me the opportunity to talk to you today about a really exciting topic, a neoadjuvant treatment for melanoma. Hopefully we can spread the message out. So before I get started, I need to have some definitions, and I think Dr. Gimbel really defined the clinically positive disease well. When we are talking about clinically positive disease, we're talking about somebody presenting with a lump. It could be a lump in one of the lymph node areas. It could be somebody had a melanoma that was removed and having in-transit disease, or it could be something picked up on the scan. So if we can look here at the PET-CT scan, we can see this is one of our patients who had a chest wall lesion. In addition to that, he had a positive lymph node in the axillary area, as you can see on the PET-CT scan. So it's a disease that's picked up either on a physical exam, or patients present with a lump, or it's picked up on imaging. And how often we see that? That represents about 15% of people with stage 3 melanoma. So what do we do for these people? What we do now, the standard of care is to do a wide local excision of the melanoma and do a completion lymph node dissection followed by adjuvant treatment. And the rationale for adjuvant treatment is the surgeon take the tumor out, as you can see here. There probably is few melanoma cells left. I mean, how can we know? I mean, we don't know. I mean, there's definitely high risk. These melanomas are high risk for recurrence, even if you take it by surgery. So the whole point of giving adjuvant treatment or treatment after surgery is to decrease the risk and the chance of the melanoma coming back. And as you can see here, when there is a little melanoma cells left, you don't expect that you're going to have a lot of activation of the immune system. I mean, yeah, you can have activation of few different T cells, and these few different T cells will go and patrol the body and try to protect you and kill the seeds, what we call them the seeds, if they are somewhere in the body. And that has been the standard of care. And we have a very good clinical trials, phase 3 clinical trials, whether we're talking about pembrolizumab, we're talking about nivolumab, or we're talking about targeted therapy for people whose melanoma harbors the BRAF-V600E mutation. All these people will get a 1-year treatment. And across the boards, these treatments decrease the risk of melanoma by approximately 50%. So they are a very effective treatment. Well, we started shifting our thinking a little bit. How about if we take few cycles of immunotherapy and just give it before we send the patient to surgery? What happened? One of my patients who underwent this treatment, and I really, what she told me, I tried to explain to her in scientific terms what's meaning of neoadjuvant immunotherapy. And she told me, well, if there's no tumor, the immune system is not going to see it. And that's true. I mean, when you have the tumor is in place, then you would expect to have activation of many different T cells, many different immune cells. Even if the surgeon removed it, as you can see, even if the surgeon removed the tumor, you are still left with a lot of activated, you have a robust immune response because you gave the immune system immunotherapy just before the tumor was removed. Then the patient comes to me and said to me, he asked me the question, did it work? Well, in adjuvant treatment, is it going to work? I don't know if it's going to work if I'm going to give you adjuvant treatment. I know there's data. I know it helps. And I hope that you are going to benefit from it. But now, did it work? Because we're having a pathology report. We can talk about complete response. Is it near complete response? Is it partial response? Is it no response? So we can tailor the treatment and helps us design the treatment after the surgery is done. What other benefits? Maybe it makes the tumor smaller and it can help the surgeon, remove the tumor, and it makes the surgery easier. Again, I just mentioned, evaluate the pathologic response. I have many times, Dr. Gimbel, he just turn the chair, give me the pathology complete response. Turn the chair, give me. It's just we're seeing complete responses. Again and again and again. This is really exciting. That helps me. That's exciting for me. When I tell my patient, we got it, and then I show them the pathology report, they say, wow, that's wonderful. So and also it helps the scientists to look at the tumor microenvironment to help advance the science. How can we evaluate response to neoadjuvant treatment? Well, there's two ways. We do imaging before we send the people to surgery, and that's the same patient I was talking about. Had a primary tumor here, he had a lump here in the lymph node. And as we can see here, we're going to talk about his case after neoadjuvant immunotherapy, 2 cycles of immunotherapy. He got a complete radiologic response, gone. We can evaluate it by pathology. As you can see here, 0 viable tumor. The pathologist can tell 0 viable tumor. That's a complete response. Less than 10% melanoma cells near complete response. And you may hear the term major pathologic response, which means both of them, the complete response and near complete response. Partial response, 11 to 50% residual, or no response. You've got more than 50% residual melanoma cells in the specimen. And I'm going to talk to you about the clinical trials that showed that any person who had any type of response, if we give neoadjuvant immunotherapy, the outcomes are great. So this is the study from Europe, Opacine Neo trial. I don't want to confuse you by the design, but basically these are people who had the measurable disease. We defined what measurable disease. We're not talking about people who had a sentinel lymph node biopsy. We're talking about people who had a measurable melanoma. And they were randomized to one of three arms. First arm, ipi-nivo, ipilimumab 3 milligram per kilogram, nivolumab 1 milligram per kilogram. That's the standard regimen we give for people with stage 4 melanoma. In the second arm, they said, well, let's decrease the dose of ipi. We know ipilimumab, they have a lot of side effect, people who had used ipilimumab. So let's decrease the dose of ipi and increase the dose of nivo. And we gave here 2 cycles, and or they get 2 cycles of ipi followed by 2 cycles of nivo. The arm A was the winner, or the most preferable regimen to use before surgery is done. Why? Because the responses are great. I mean, 77% compared to the first arm, which is 80%, but the side effects slashed by half, 20%, a grade 3 and 4 toxicity. So that's really great. And that's what they used in another trial, an extended trial that I'm going to be discussed next. It's called the Prado trial, with an extension for this cohort. And we'll discuss it in a couple of slides. Look at the event, 2-year event or recurrence-free survival. So that means the people who did not have any melanoma at 2 years, 83.6%. And if we look at the subgroup analysis, people who responded, any response, near complete or even a partial response, 96.9%. How about, adjuvant treatment? All the clinical trial of adjuvant treatment, what's the recurrence-free survival? We just said about 50 to 60%. We're raising the bar here. When we're giving immunotherapy before surgery, we're having 96.9%. That's really exciting. This is the Prado trial, the same group in Europe. They have adopted the arm B regimen, what I call IPI1, Nivo 3, and they enrolled people with measurable disease. And what they did, and this is part of a clinical trial, this is not the standard of care. Again, in the United States, still we do completion lymph node dissection followed by the treatment, adjuvant treatment. But when we want to do immunotherapy, we give a couple of cycles before the surgery. In this trial, they're just taking one lymph node. They call it the target lymph node. They remove it, send it to the pathologist, and if the pathology came as complete response or near complete response, they're not doing surgery. They're not doing even immunotherapy, just observation. If there is a partial response, they do surgery alone, no immunotherapy. And if there is no response, these people, they do a completion lymph node dissection in addition to the full year of treatment, which is the standard of care, either immunotherapy or target therapy based on the BRAF mutation, if the melanoma has a BRAF mutation. Again, this is not the standard of care, it's part of the trial. But look at the results. Again, 2-year event or relapse-free survival, 85%. And when we look at subgroup analysis, people who had a major pathologic response defined as no melanoma, 0 melanoma, or less than 10% melanoma left in the tumor, we have a 2-year event-free survival or relapse-free survival, 93%. But look at the group who developed partial response. I mean, you would imagine the people who, how come people who did not respond did better than people who had a partial response? Well, I mean, we have to this results raise the question that we perhaps need to give immunotherapy for people who had a partial response. I mean, they should. And in this trial, they did not get immunotherapy. That's the reason it's an evolving field. Whenever we have a clinical trial in our institution for neoadjuvant treatment, we have to enroll people in this clinical trial because we need to get the answers for really important question like this question. But if there is no clinical trial available, we are doing, and I'll tell you about the regimen and what we are doing in terms of neoadjuvant treatment. So we go back to our patient. He presented to us, I believe, in 2020, and he had a chest wall lesion. And he came in and with a big lump. And the PET-CT scan is showing that. So we talked to him about neoadjuvant treatment. We did not have a clinical trial open in our site. We really believe in this. And we, by analyzing the results and the data coming from Europe and coming from the United States, it was just a natural transition for people like physicians like myself. When we care for people with melanoma, we have seen it working in stage 4 disease, eliminating the disease. You've got brain mets, you give immunotherapy, it wipes it out. We see it working in adjuvant treatment. It was very natural to adopt this in our clinical practice. So we talked about 2 cycles of Ipi/Nivo. We were planning to give him the 1 milligram per kilogram, like the same trial done in Europe, 2 cycles every 3 weeks, and then do the surgery, and then meet him after the surgery. Well, he developed diarrhea due to colitis, and we had to treat him with prednisone. Thankfully, the diarrhea was not bad and actually resolved by the time he came to see me for cycle 2. In cycle 2, I talked to him. I said, well, typically we give Ipi/Nivo, but I'm worried about your colitis, your diarrhea. How about we go with just one drug, was Nivo? And we gave him just 1 dose of nivolumab. And then he developed colitis again. And I said, that's it. We're going to treat you with prednisone. We're going to take care of the colitis. We're going to send you to Dr. Gimbel for surgery. We did a scan for him, complete response. So complete radiologic response. And he underwent the standard of care in the United States, again, completion lymph node dissection. And there's 0 melanoma. This is a complete pathologic response. And that's his PET-CT scan in May of 2023. He continued to do great. I think we're seeing him every 6 months. He's looking to be seen every year. I have no doubt that we got this melanoma, and I think even going to a year would be fine. But it's really, really exciting. Dr. Amaria at MD Anderson in Houston did a small clinical trial there. They have published their experience with Opdualag. And Opdualag is a combination of nivolumab and relatlimab. And the nice thing about this combination or Opdualag therapy is the side effects. I mean, the grade 3 and 4 toxicity in stage 4, when we give it to people in stage 4, is only 17%. When we think about the combination of ipilimumab and nivolumab, it's really having a higher toxicity than Opdualag. So it's a really nice treatment for people with stage 4. So she applied it in the neoadjuvant setting, and she is using it. She used it in 30 people with, again, clinically positive disease, gave 2 cycles of this Opdualag. It's given once a month. So within 4 weeks, you get 2 cycles. And then you go to surgery. And then she followed them after surgery and gave them the same treatment to complete a full year of adjuvant therapy. And again, the responses, if we look at this figure here, the pie, we've got most of the people, the complete response is in 57%, near complete response, pathologic complete response in 7%. Altogether, including pathologic partial response, is about 70% of the people have any pathologic response. And if we can look at the survivor curves right down here, we see again that most of the people who got neoadjuvant treatment at year 1, actually 100% recurrence-free survival. And at year 2, it's 92%, while people who did not respond at year 1, it was 88%, and at year 2, it was 55%. So again, I mean, neoadjuvant treatment is really, really exciting. I'm going to talk here about the S1801 clinical trial. So if we look at arm B, or the second arm, this is a standard of care in the United States. To do surgery, do completion lymph node dissection, and take a year of immunotherapy, whether it's Opdivo or Keytruda. In this trial, they gave Keytruda. Then the scientists in this trial, I said, how about we get just the 3 cycles of Keytruda and we give it before? Just the 3 cycles. It's genius. This is confirmed why, the rationale behind doing neoadjuvant immunotherapy. Look at these curves. Just by getting 3 cycles of Keytruda and giving it before you do the surgery, you get a better 2-year event-free survival for people who got neoadjuvant Keytruda versus the people who got adjuvant Keytruda alone. That study is absolutely genius, and it confirmed to us that neoadjuvant therapy is the way to go in the future. At this point, it's important, the first point. A lot of people are anxious when we meet them. I want this tumor out. I want to go to surgery right now. Well, you can go to surgery right now. I mean, as a matter of fact, if we look at that people who enrolled on adjuvant treatment, who got the surgery right now, and they are ready to go to adjuvant treatment and receive, if you look at those people enrolled in the clinical trial, about 15 to 20% were excluded from the trial. And you know why? They have stage 4 disease. This is why, if you want to get the surgery right now. So yes, here in neoadjuvant treatment, we have about 5% of people may end up having metastatic disease, but we spared them unnecessary surgery. The biology of the tumor is off. I mean, if you're going to have metastatic disease within 6 weeks from diagnosis, you better not go through the surgery. But it's 6.5% in this trial. Look at the people who went through surgery and they're having 11% metastatic disease. So again, neoadjuvant treatment, the message is neoadjuvant treatment is the way to go in the future. So conclusion, neoadjuvant therapy allow for rapid assessment of pathologic response and radiographic response. Any pathologic response is good if we give immunotherapy. Now in targeted therapy is different. If people who got targeted therapy for surgery, you got to have a complete pathologic response to have a good outcome. Not, a partial response, near partial response is not going to work. That's the reason immunotherapy is the way, not targeted therapy is the way. Should we give Keytruda alone, single agent or double agent? I think it's dual agent immunotherapy. And the data tells us when you give dual agent, you have a better event and recurrence-free survival, though they were not compared to head-to-head. And hopefully stage 3 trials in the future, they will give us the answer. So the available data from phase 2 studies challenge the current paradigm of surgery first, then followed by adjuvant treatment for people with clinically positive melanoma. And thank you very much for listening. I think we're going to have a question and answers right now.
That was great. You can see the excitement that Dr. Mahmoud has with treating neoadjuvantly, and I think we all feel the same way. So this is really exciting. We're going to move into the question and answer. Because we are doing this online and we only have our one camera here, I'll ask the question and then we'll have whoever needs to or wants to answer the question will come over and answer in front of the computer. Okay, so if you want to answer the question, or if I call on you to answer the question, I'll have you come over here. So let me just read through what we got. A couple of these here, and I think we'll start with looking at some of the genetic testing. So we had a question about genetic testing, and the question was, how advisable is genetic testing for somebody who has multiple cancers, maybe breast cancer, cervical cancer, and melanoma? What's advisable for genetic testing in someone who has multiple cancers?
Yeah, that's a really good question. So you would want to have a discussion with your physician if you are concerned about that, because we know that melanoma is linked with some other cancers when we're looking at particular genes. However, just in general, having another cancer is not necessarily a risk factor, or even 2 or 3 other cancers. It really depends on what those cancers are that have been linked to the genes that we know. So sometimes we talk about pancreatic cancer rarely kidney cancer, and there's some of the breast and ovarian syndromes that have a slight increase for melanoma. But other types of cancer right now, we haven't identified genes that necessarily are related.
And I would offer that while we may not find a germline mutation, somebody has multiple cancers, there is something in your genes that predispose you to cancer. Because there's people who smoke who never get lung cancer. There's people who smoke and get lung cancer. There's also something about your genes that can predispose you. And it may still be worthwhile if you have multiple cancers to get genetic testing. We may not find something, but who knows? Maybe we do. So I think it is worthwhile to do that. Also, in terms of risk of other cancers, someone has asked, since I have a cutaneous melanoma, and am I at increase for other types of melanoma? What are the types? There's uveal and there's mucosal. There's been a lot of research looking at the other types of melanoma and are you at risk? So if you get a skin cancer, do you need to go get your eyes checked for an ocular or a uveal melanoma? There's been no good data to support a communication or connection between the two genetically. We know that cutaneous melanoma has a high mutational burden. Uveal melanoma and mucosal melanoma have low mutational burden. So there's something different. We know that the ultraviolet from the radiation that pounds your skin is going to cause that melanoma to occur when it's not ultraviolet radiation exposed, such as mucosal, the mouth, or in the eye. It's going to have another pathophysiology or another reason for coming. So they're not necessarily linked. So anybody who has a skin cancer, skin melanoma doesn't really need to go for an eye test. I know there's concern because they're all melanocytes, but it's not been shown in the studies that they are directly communicated. We'll get to you in just a second, Dr. Mahmood. I'm going to get through some of the early stuff first. So this is a question about the pathology. What's the significance of the mitotic rate in determining chances of recurrence? So when you look at the pathology report, I don't know, do you have any thoughts in terms of the mitotic rate or?
I do. Yeah. A higher mitotic rate definitely can indicate a tumor that maybe is a little bit more aggressive. The mitoses are representative of the division that's going on within that tumor itself. However, our current staging system in the United States is not really taking mitotic rate into account. So there's not going to be a different intervention for melanoma that's the same depth. And usually it does correspond where you see a deep melanoma usually would be the one that would have a higher mitotic rate than these early melanomas. That would be very rare.
When I'm managing patients surgically, I do use the mitotic rate for worrying about risk of recurrence if someone does have a highly active tumor. If I have a patient who has, say, a 1 millimeter tumor that's close to that cutoff, and maybe the patient doesn't want a sentinel lymph node biopsy, they don't want further surgery, I could look at the mitotic rate. And if they have a high mitotic rate, I may say, well, this may be a tumor that we'd want to consider doing something. Or, okay, you don't have any mitoses, the tumor is not active. And what is a mitotic rate? When we look under the cell and see cells dividing, that process is called mitosis. And if you see that process under the microscope, if you can see one of those dividing cells, then you have a higher mitotic rate. And so if you see multiple of these, you know you have an active cell, and that's what the mitotic rate is. And so we can use that to make some determinations. It was taken out of the staging for melanoma, but I think in the future it will get pushed back in because we can't ignore it. All right, here's a good one for Dr. Mahmood. Is neoadjuvant immunotherapy the new standard of care? All right. And is there any reason, as you have kind of alluded to prefer adjuvant over neoadjuvant? Why would somebody want adjuvant over neoadjuvant?
Well, that's I need to be politically correct here. I mean, it's not yet the standard of care. Again, we encourage people to get enrolled into clinical trials. But I think for me, having cared for people with melanoma and have treated people with a stage 4 and use the adjuvant treatment, I think my interpretation of the data, I think I'm ready personally. If I don't have a clinical trial in my institution, I would definitely advocate for putting people on neoadjuvant treatment. I think I really, really, truly believe that if I have right now, like today, after all this data coming out, if I have a stage 3 clinically positive melanoma, I would like to be treated in a neoadjuvant setting. As for the adjuvant treatment, well, that's a tough one. I mean, again, I probably answered it. Again, I'm advocating for neoadjuvant treatment, but if you ended up having the surgery, of course, I mean, we will definitely give the adjuvant treatment because, again, adjuvant treatments have been supported by data, have been supported by phase 3 clinical trials. All the neoadjuvant treatment, I'm going to re-emphasize, they are phase 2 studies. We don't have yet a well-designed phase 3 clinical trials for me to say this is the standard of care. If you go to NCCN guidelines, they have listed it as an option and level 2, not level 1 evidence.
Great, thank you. There's a couple more surgical questions I'm going to answer, and then we'll move into, there's a lot of questions about side effects of immunotherapy and some questions there, but I'll go through a couple questions here real quick. The first one is, does somebody need general anesthesia for a wide local excision? The answer to that is no. A lot of times we can do wide excisions in the body. It does get local anesthesia. It's not as bad as going to the dentist when you have to have a root canal, but it isn't comfortable. But once patients are numb from the local anesthetic, then we can do the procedure in the clinic setting. And I do a good number of those, as does Dr. Abbott. However, when doing the lymph nodes, a sentinel lymph node biopsy, we do prefer general anesthesia because sometimes the lymph nodes are very deep along the chest wall. There's vessels or nerves around there, and we do need the patient to sleep for that. How often does a melanoma of the shin progress to lymph nodes and other parts of the body? So this is understanding the lymphatic system. As I showed in that diagram, where the body drains to certain lymph nodes based on the melanoma, it is extraordinarily uncommon for a lower extremity melanoma to go to the armpit. We just don't see it, and that's just from the way the body is structured. I won't say it's zero because I'm never an absolute. I'm a physician. I know things aren't absolute around here, but if someone has a lower extremity melanoma, it's going to go to the groin. If it gets to the lymph nodes in someplace else, that's stage 4. We're now talking about a different disease. Let's see, that answered that. All right, this is an interesting question. So someone was diagnosed with stage 2 melanoma. They underwent a wide local sentinel lymph node and they had cancer in their sentinel nodes. In the future, would they have been eligible for neoadjuvant therapy? And I'm going to take this one if you don't mind, because the answer to that is no. The reason we do a sentinel lymph node biopsy is because we don't know if there's cancer in those lymph nodes. We take those lymph nodes out, and ultimately, if there's cancer in those lymph nodes, then we would give treatment afterwards. But I do want Dr. Mahmoud to come up because there is new data looking at stage 2 melanoma, talking about adjuvant therapy, giving treatment after stage 2 melanoma. And if we're going to treat people afterwards anyway, if someone has stage 2, should we treat them before surgery? This is completely out of the box, but I kind of want to see what he thinks about that.
For stage 2 melanoma, we have stage 2B and 2C melanoma. We have a data. It's a phase 3 trial. It's one of the keynote studies that showed that giving 1 year of Keytruda or pembrolizumab decreased the risk of recurrence and death by 35%. So I would stick to it. I don't want to comment about the neoadjuvant. No, I don't think I would do neoadjuvant treatment for stage 2 melanoma.
Okay, we have a question that says, if a person has 2 siblings with melanoma and this person has a large amount of atypical nevi, or sometimes there's this diagnosis called atypical melanocytic proliferation. So they've had these multiple of these diagnoses in the past. Is there anything additional they can do beyond skin cancer screenings? So first off, I would say this person, if you have 2 siblings who have had melanoma, you are a good candidate for having that genetic testing yourself to see if there is a gene implicated, if this is a hereditary type of melanoma. And then as far as, is there anything else that can be done to monitor all of these atypical moles that this person has? I would recommend that they see a dermatologist who is performing some sort of total body photography when they're looking at the patient and evaluating them, and that they're using the tool of a dermatoscope to evaluate their nevi. That's really helpful for looking at the pattern of those melanocytic proliferations there and differentiating something that may be benign versus malignant. The total body photography can also be really helpful for comparing lesions, because sometimes when these look abnormal, the best way to determine if there's something suspicious going on there is to detect a change with it. So when we're monitoring with photography, that can be as simple as, taking photos of different areas of the body and then comparing them during your next exam. But when you're doing that side-by-side comparison, you are able to detect if one of those moles has changed.
Okay, great. Let's get into some of the immunotherapy questions because we have a lot of questions about that here. We know that immunotherapy does cause side effects. What are some of the common side effects you see? What does that mean for treatment going forward? And if someone has to stop for side effects, when can they get on to either back on treatment or other treatments?
That's a great question, and I have not addressed it. Side effects of immunotherapy are real. I mean, we do run to really severe side effects, but the way I think about it, I'm talking in general, I'm not talking about neoadjuvant. I'm talking, let's say I'm treating somebody with stage 4. I mean, to me, the side effects is also a way to think that, yes, you got side effects because the immune system was very hyped up. And in the Checkmate 067 clinical trials, people who had severe side effects, they had to stop early. You know, some people got 2 cycles and we stopped. And our patient actually in the neoadjuvant treatment, he did not receive anything after that. And still the melanoma in control. We had people with stage 4 melanoma that we had to stop after 2 treatments because of severe side effects. Discontinue the treatment, not even restart it. And despite that, we continue to see this durable responses for years and years. But the common side effects that we see, flu-like symptoms, we see skin rash, itching, diarrhea due to colitis. We have endocrinopathies like hypothyroidism, hypophysitis, inflammation of the liver, hepatitis. And some of the side effects can be chronic, you know, like arthritis. And I have some people like rheumatoid-like symptoms that can be chronic for years, and they need to see a rheumatologist. Some people have itching that can last for a long time, or skin rash that wax and wane. Yeah.
And let me keep you up for 1 second, Dr. Mahmood. Is there any, I know people have said that if you have a reaction to immunotherapy, you may have a better response to immunotherapy. If you are getting these side effects, if your immune response is so robust that you're getting, do people do better if they have these side effects, or is there any relationship to side effects and treatment response?
Honestly, clinically speaking, I've seen it in my clinical practice that the people who have the severe side effects, you know, a lot of times I end up really stopping the treatment. We're doing a scans and we see that melanoma went away. I would say that, you know, if you have a severe side effect and if you develop a response to the treatment, most likely the treatment would be durable. I will leave it there. I'm not going to claim like probably if you have that we would like you to have more side effects, because we have seen people also with no side effects to the treatment and still they develop. Some people with very subtle side effects. But I think if you have a severe side effect and responses happen, yes, the responses continue to be durable. And that's a good sign.
Okay, we talk about the immune. Don't go too far. This is. So I don't want to get into too much about patients' individual treatments. I'm going to try to keep this a little bit broader. So for those of you who ask questions about your treatments, I'm sorry if I'm not going to address those, but they can be submitted to the AIM at Melanoma website. There is an area to ask the expert there, so those can be directed there, and I think that's a great location for that. But with immunotherapy being used and we see patients who are doing well, what do you think about the concept of a booster, reamping up the immune system in the future to maintain that response? Do you think that's we talk about, there's a treatment that are vaccines that we use. Do we think that patients' immune system will last indefinitely?
So as of now, if the patient received treatment for stage 4 melanoma and they're doing well and the melanoma went away and we're doing surveillance only, we don't do any boosters. If people with stage 4 melanoma, for example, getting ipi-nivo and then they went to nivo and for some reason it happened that they ended up having recurrence, then yes, we can re-challenge with the same treatment like ipilimumab. We can re-challenge with ipi-nivo again and then continue nivo. Other than that, there is no data about giving anything to boost the immune system. In terms of vaccines in the future, maybe vaccines, and there's a lot of exciting things. We're learning a lot from the COVID vaccine, and trying to learn from that technology to develop a melanoma vaccine that is already in phase 1 trial combining with Keytruda. But this is really early and very premature, so I'm not going to get into that yet because we don't have really sufficient data to recommend it as a standard of care.
Stay here. Also, people are asking about cancer vaccines for melanoma as well as TIL therapy. Can you speak a little bit about that, please?
So the cancer vaccine, I was just talking about it. I mean, we're learning. I mean, we have trouble with the COVID. We went through it for 2 years. We have this wonderful, invention, or it was there, the RNA, vaccines, but now they're coming back to spotlight. And what they're doing is trying to develop a melanoma vaccine. And when they combined it with Keytruda, these are people, instead of doing adjuvant treatment, for example, with Keytruda alone, in the future, if the clinical trials prove that this is effective, you may end up having Keytruda and a vaccine that can prevent you from having melanoma. Again, we don't have enough data from phase 3 trials, so and it's not in a clinical practice. But I think if you have an option of being enrolled in one of the centers that they can offer this adjuvant treatment of a vaccine plus immunotherapy, then certainly it's exciting. And as for TIL therapy is important, especially for people with a BRAF wild type stage 4 melanoma. I mean, for BRAF wild type melanoma, we don't have.
What is TIL therapy?
TIL therapy is basically taking part of the tumor, sending it to the lab, giving it some nutrition. We give it some high dose IL-2 and let it grow in the lab, not the tumor, I'm sorry, removing the immune cells from the tumor and growing it in the lab to millions and millions of cells, and then re-inject it back to the person. So it is a very good salvage therapy, and it really fills the void, especially people with a BRAF unmutated melanoma. If they progress on the treatment that we have nowadays, TIL therapy is an option. It can help in about 35% as a salvage therapy and help 35% after you fail even immunotherapy. So it's really an exciting thing to do. But it requires people who are extremely fit, because they're going to get high dose IL-2 treatment and preparation for the immune cells to be re-injected to the body. So and there is it's submitted to the FDA, and we're waiting for the final approval for it. There is a product there for TIL therapy, but it's not yet approved by the FDA as of yet, but it's submitted.
We had a question that said, do you recommend neoadjuvant treatment for lentigo maligna melanoma? So lentigo maligna is a type of melanoma. And usually when we're talking about lentigo maligna, if you remember Dr. Gimbel's slides that showed the skin sections and how deep the melanoma is going, lentigo maligna is usually that stage 0, the melanoma in situ that's just on top of the skin that has not invaded at all. So someone who just has a stage 0 would not be a candidate for neoadjuvant therapy. Rarely someone can have a lentigo maligna subtype of melanoma that has invaded further, and then we classify that as we do any other type of melanoma. So it really depends on if it's an invasive disease, which is rare for lentigo maligna melanoma.
And so to follow up with that, are there topical treatments for melanoma? If someone has an early stage disease, is there something that we can use on the skin as opposed to cutting it out?
Yeah, that's a good question. So for people who do have that lentigo maligna melanoma, that's just stage 0 on the top of the skin, or melanoma in situ, sometimes after surgery, they will still have some positive margins, or maybe the person doesn't want surgery and isn't a good candidate for surgery. We can use this topical therapy called imiquimod. That is usually about a 3-month treatment course that really activates the body to fight off the abnormal melanoma cells that are there.
Great, thank you. Just a couple more questions. We have about 3 or 4 more minutes. Dr. Mahmood, if somebody has stage 4 melanoma, how long do you treat them for? Is this a lifelong treatment, or can you stop at a certain time?
So the standard of care right now to treat stage 4 melanoma, if we're treating them with immunotherapy, is to go for a total of 2 years. But again, I had people who had 2 cycles. And those people who had 2 cycles, the outcome were not different. If they responded, they were not different than the people who had 2 years of treatment. I mean, that's the beauty of immunotherapy. It's like when it's stimulated and the immune cells get to know the tumor cell, the melanoma, it just keeps attacking it. It's part of your system. Nobody can take it from you. That's the whole premise of immunotherapy. Your immune cells will defend you in the future. So I have treated people with 2 cycles and I have treated people with 2 years. And the reason for 2 cycles, of course, the side effect. I'm sorry, the reason for 2 cycles is a side effect. I have to stop because of the side effect.
You good? You good? All right. Okay. So I want to touch on one more question. Someone asked a question about genomic profiling of a tumor. So there's a test out there called the Castle test, and there's other tests out there as well. Just to disclose, I do speak for Castle, so I have to give that disclosure. But in terms of genomic profiling and using the Castle test, I think genomic profiling is very important. And I think we can identify a lot of tumor behavior based on the biology of the tumor. Ultimately, it's my thought that we're going to biopsy somebody's tumor and we're going to be able to see upfront what's that tumor going to respond to, how's that tumor going to occur. And I think understanding the biology of cancer is really important, whether it's the Castle test or another test that may come to play. But I think we can't downplay the biology of that initial tumor. And so when I use the Castle test now, or any genomic test, where I'm actually predicting risk of recurrence, predicting risk of the spread to the lymph nodes. And so I use that test, but there are other tests out there that can also be used. The patch test that Dr. Abbott spoke about is also a genetic test, looking at the genomics or the genetics of the tumor under the microscope and deciding, is this more cancerous, is this not? So I think there's a lot to be said for using the biology of the actual tumor, and I think that's only going to increase even further. So with that, I'd like to say thank you so much for at least the first part of our day. I know you're here with me in place, so you got to stay for the second part, which you're not going to want to miss. And for those online, please stay. We're going to take a short break, and we'll come back for the second part of it. Thank you.
There was an I'm just going to put this forward. You've got a little 10-minute break.
Perfect.
I don't want to move this just because it's
Yeah.
in place.
Kristen, are you there? You're muted right now. Kristen, can you hear me?
I think I'm your first student. Nice to meet you too. Dr. Vince. Yeah, because I was supposed to be the PA with one derm. Yeah. And then I get a credit, like, spend my life, like, I need to do derm right on my way, so I'm so thankful that they had the. Yeah, I got your email. So. Yeah. You have it, one for me. Yeah, we were good. I asked Dr. Vince to be very helpful, so. Okay. Yeah.
University is
You'll see
much better.
Yeah.
Yeah.
Yeah, that would be, yeah, I'll come to copy up. Yeah, that sounds good. Yeah, that's fun.
Yeah.
About 2 more minutes, I think.
Yeah. Still stay the same. But Cam has actually pretty much.
Well, good.
When you're doing both.
Yeah.
It's for the same thing. What's really good, like where it sounds.
Yeah. It's hard. Yeah. Yeah. I got 3. I honestly, I think. They're happy. They have heard people say, like, he's a doctor, you know, yeah, and then he set it up, and so, you know, like, there's a lot of confusion of like, hereditary cancer versus now. Yeah. 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 Yeah.
I'll give it.
Yeah. Really? Yeah. Yeah. So I can find your email. Email is gonna be full. Are you talking? Or first time, because we're doing my DMG. Yeah, but for you guys out. Wait. Oh, so they start, I mean, like, it's almost like. Oh. Yeah, so like, you're, yeah. Yeah.
Am I live? Okay. There we go. All right, so I hope we all had a nice little break. Got to refresh. We're now gonna jump right back into this to the next portion of the morning. This is I'm really excited about this because I think this brings an added dimension to what we offer from a cancer center. It's not just, hey, let's treat patients' cancers, but let's treat patients. Let's kind of treat the patients holistically. So the first I'd like to do is introduce Dr. Rina Szabo. Pardon me, I just lost your introduction here, but Dr. Szabo has been a colleague of mine for many years. She's the head of the Department of Psychology here in the Banner Medical Group and does wonderful work with the cancer patients. And I'd like her to come and present Living with Uncertainty. Thanks.
Hi, good morning. So I'm Rena Zabo, and I have this really unique and privileged space in our community here. We deal with cancer, and my theory is we can get rid of the cancer, we can treat the cancer, but if we don't treat the soul and the person and the family, then you're broken at the end, whether you're cured or not, or disease-free or not. So if we don't look at it from a person perspective, we're doing a disservice. And I get to work at that intersection of psychology and medicine and add a different approach from my very scientific colleagues. Definitely a different type of a training, more about the psychology and the neurology, if you will, that I kind of spend my time in. So today I wanted to talk a little bit about cancer recurrence, and I have no disclosures. So you will have fear of recurrence. It's normal. You know, anxiety is normal. A burglar alarm is there to stop burglars. You don't want to turn it off, right? Because then the burglar may just burglarize your home. So you don't want to turn off that anxiety. You don't want to turn off that fear, but you want to be able to manage the fear. And so our brains really crave that information to keep us alive. And that's what it's telling us. Something's wrong. It's a cue that may have gotten you into your first initial diagnosis. But how do you keep that from hijacking you and taking you down a path where you're focused more on recurrence of cancer than you are on your life and your loved ones and your quality of life, right? So whenever we do not feel in control, you know, there's that ambiguity. We want to control it. How do you go against that? How do you fight that? And we'll talk a little bit more about that today. But the worry is not bad. The fear is not bad. It's just the level of it. So I'm sure if you're sitting here or you're online, you're thinking, I've thought these things, I've said these things. Will my cancer come back? You say it to your loved ones, you say it in your own head, you say it to your providers. Will it progress? Will I get a secondary cancer related to the treatment that I had? Will I recognize the symptoms? What do I pay attention to? I mean, I was diagnosed and I was fatigued. 2 years later, I'm fatigued. What does that mean? Do I dismiss my thoughts about it because I'm over worrying? And my family tells me I'm just need to let it go and I'm over preoccupied with this thought. And am I doing enough or am I overdoing it? Right? So all those different types of questions not only impact you, but impact your family. So when I talk about fear of recurrence, it's a relationship topic because how you're educated on your fear of recurrence and how you educate your family members on your fear of recurrence is really going to change how those relationships go forward in your survivorship. So fear of melanoma recurrence, it actually FMR, it actually has an acronym for it. It's a different, you know, fear of recurrence of cancer is a general statement, but there's some specifics to fear of melanoma recurrence. Younger people seem to have a greater height of that fear. Older people seem to have a little more management of it. And it's not to say that it's not important in both. And I don't know if it's because as we age, we say we've had this great life, we don't want to give it up. And the younger individuals say, well, I haven't even had a chance at that life. I have more life to think about this. So not sure where that comes from, but it's just something that's out there in the literature. So worrying about that cancer coming back, mild is healthy. I hope that every patient in our cancer center has some mild fear of recurrence, and specifically for melanoma, right? We've talked about different types of melanoma. I think kind of like the smoking issue that was mentioned, you know, our behaviors, what we think about a lot of times in melanoma, it's our behaviors that have caused this, right? Or our environments that have caused this. So you try to change your behaviors. Or when you're talking about fear of melanoma, if it is a genetic component, right? Oh my gosh, I can't even get away from it. I can't even change behaviors, but you can, because your behaviors, no matter if it's genetic or if it's environmental, your behaviors can turn things on or off. So you always are part of the treatment plan with your lifestyle and your behaviors, right? If you're not a part of the treatment plan, nothing that we do in that medical record means anything. So when we're talking about moderate fear of recurrence, a lot of times my colleagues will see this and they'll see it in terms of, can I have an extra test? Or I'm not supposed to see you for 6 months, but how about 3 months? You know, you start to do the negotiation. And what happens here, you know, I'm putting this up here, but I'm really more speaking to it, is that you see either avoidant behavior here with the moderate and the high, or you see a preoccupation with reassuring behaviors. And the avoidant behaviors, we know, I mean, many of you at certain times, if you've dealt with melanoma, have avoided going to events outside possibly, right? Or you've avoided certain things during your treatment because you don't feel well, you don't look well, and you isolate. Cancer is very isolating sometimes. That in and of itself is a behavioral process that you and your loved ones have to manage and use protections as far as the cancer risk. But when it comes to the reassuring behaviors, it's like a drug, right? So, you know, Dr. Mahmood, I know I just saw you 2 weeks ago, but I'm calling your nurse right now, and I have found another. Can I just make another appointment? And we say, okay, yes, come on in, have another appointment. And it's like the drug dealer dealing the drug, but it's almost this, it's this bad position that we're put in because we are in a medical field and we want to pay attention. We don't want to miss anything, but we also don't want to feed that high or moderate fear, right? Because then you're not living. And cancer will win. I don't care where you are. If it has more attention in your life than the things around you that you love or the people you love. So remember that. So when you're fighting cancer, when you're surviving cancer, I've heard this a million times, we all have. I can't wait until my treatment is over because guess what? Then I'm going to do this. I'm going to live like this. No, that starts at diagnosis because otherwise cancer is winning no matter what. You better be living through this. And whether it's a psychological thought process, a behavior, those things cannot take over because they are connected to the cancer. Right? So there's a lot of conceptualization on the melanoma. Just because of the societal impact on sun safety, we tend to focus on that. Just like in the past, we focused on lung cancer and smoking. More than half of my patients are non-smokers and never have smoked. So there's this unknown part of how this comes to be, right? For people who are not in it, you know more about melanoma now, right? Things we never knew before until you're sitting in that appointment or with that diagnosis. So we have high levels of preoccupation, high levels of worry, persistence, and then hypervigilance of bodily symptoms. Is that you? Is that someone that you love? Are you that spouse that says, if I have to look at one more mole? Or are you that person that has the little mole sheet sitting there and you're going around? Is it too much, right? If you think about fear of recurrence on a level of 1 to 10, anything over 5 is controlling you. Anything under 3, you're fine. Warning signs come at 4 and 5. So it's up to you to get educated on fear of recurrence, but specifically your triggers, because it's not going to go away until the day you're no longer on this earth. You now have a different paradigm of the world. So when you look at the literature out there, when you look at different cancers, we have fear of recurrence levels that are, you know, different based on the disease type. So with survivors of metastatic melanoma, right, we have 86% of them have been shown to have moderate to high. That and lung cancer are probably the highest fear of recurrence levels. So you have to ask yourself, did you know this? Are you experiencing it now? Did you ever realize in survivorship that this was going to be something that was going to hang out with you, that uninvited dinner guest that you're like, wait, you weren't invited, please leave? No, pull that chair in and let that fear sit at the table. Don't push it away. The more you push away any type of fear or anxiety, the bigger it gets. So are you going to be a storm chaser, or is the storm going to chase you? So when you look at fear of melanoma recurrence, and this is where age comes in, female, gender, and I don't know why I doubled that, just because I'm a female. I guess I decided to do that. Please forgive. Your baseline symptoms, employment or unemployment. So they find that people who are employed have less fear of recurrence, which makes sense, maybe more of a distraction. Latina and Latinos have a higher fear. The type and the length of the treatment, the longer and the harsher, cause more fear. Physical symptoms, side effects. If you have lung cancer and melanoma, you're almost at a 99% actually when it comes to fear of recurrence if you have both cancers. The multimodal modalities of our options of treatment, and that is going to be coming again more and more, as we've heard today from Dr. Mahmood. How much do you know about your disease process? How much do you know about the medical processes and the education about your disease and the treatments and the outcomes and the survivorships, how severe it is, and your educational level? And 97% of all cancers have a mild fear of recurrence. But again, like I said, melanoma and lung are the highest. You put them together, and that's a real tough one. So how does it show up? You know, constantly checking mold. We kind of mentioned that. Emotional numbness, uncertainty, withdrawing from friends and family, not making plans for the future. Just ask your question that during your treatment or diagnosis, at any time did you just cut off the future and thought, I'm not going to go on that trip. I'm not making that cruise reservation because I don't know. I've had so many patients just stop future plans. Difficulty focusing, poor sleep, and avoiding medical appointments. I know that I have patients, I'm sure we can all say we have patients that you're going through and you meet patients and you have a lot of them, and all of a sudden one day you go, gosh, I remember this person. I wonder why I haven't seen them. You know, and is it because why? Are they just afraid to come back to find out? When does it occur? So I kind of put it in a category of 6 areas. Diagnosis, that's when it starts, right? Anniversaries of treatment, anniversaries of diagnosis, anniversaries of anything related to your melanoma. Anniversaries are huge. They come every year. So they're not going away. Get used to them and look at them as something other than dread, right? If you didn't have an anniversary, you wouldn't be here. So when you also think about media, I mean, I think about some of my patients that I've sat in appointments with after Olivia Newton-John, or, you know, when we had Tom Petty. I mean, all of a sudden, people I haven't seen, they had a connection to that media figure, and it brings up some angst. Medical appointments, you know, whether it's every 6 months, every year, non-medical appointments, like when you graduate, right? Wait a minute, I was here all the time. These people knew me by name. Now I don't even come to this building. Now what? Right? You're handing me back to my primary care? No, I want to stay with you, you know, that kind of a thing. I'm yours now. So those are some of the areas as well. when symptoms come, whether they're related to your cancer or not, you know, that hyper focus on your body. And also when you have loved ones or people you care about, might be a completely different cancer, but it will prompt something in you. So know those are 6 potential areas and start to pay attention and plan for them. Like I can tell you on average, I see people coming in who I see people more regularly and then others infrequently. But when scan time is coming, 2 weeks before, all of a sudden they're back in my office. And then we work through it because it's that fear of last time I had a scan, what happened? Or the last scan was good, but what if it's not this time? I have one patient, actually a melanoma patient survivor, who does not drive on the 60th in order to avoid this hospital. Does not want to see this. So like takes back roads unless she has to come here. So, I mean, those types of behaviors are part of this, right? And you know what? It's like I said, it's very natural. It's a human experience, right? Our brain is made for fight or flight. Our amygdala is our love-hate center. You know, I call it amygdala hijacking, takes over everything that is common sense goes away. And you're just like going in a direction you don't even know where you're going. So you have that alarm stage, right? And this is kind of when your central nervous system is ramped up and it prepares your body to fight or flee. And at this point, your cortisol is raging, right? Inflammation starts in your body at several different levels. And that's fine. Our body's supposed to do that, but then it's supposed to calm down and go away. When this becomes chronic, this fear just never has a pause. That's when all of that inflammation hangs out longer. Your cortisol's messed up, your sleep's messed up, your thinking, your concentration, your focus. Those are the things that we talk about from the biopsychosocial model, and that what can you do in your world to add to their treatment plan or my treatment plan, our treatment plan. That's when you say, okay, cancer and inflammation love each other, right? So what can you do behaviorally to get rid of it? How do I manage my stress? How do I manage those fight, flight hormones that are raging through your body over time? The resistance stage is when your body does attempt to normalize, right? And recover from your fear. But then what happens if you can't manage it is the exhaustion stage, right? When you're just exhausted. Over time, it's chronic and you just are either numb or shut down. We have a lot of GI issues with fear of melanoma recurrence. We have a lot of depression, headaches, migraines, some cardiac issues. Many people end up in the ER and it's a panic attack, not a heart attack. But also those rising hormones impact your immune system. And we have a team here who's trying to help your immune system fight the cancer, not fight you. So asking yourself, is it true? Trying to balance your thoughts, give yourself some grace. If you're a family member and you're annoyed by that individual, give them grace, learn about it, talk about the fear of recurrence. If you haven't been in this position, you can't really understand it, right? Don't hide, don't run, chase. Let go of the fight, right? You know, the more you fight it, the harder it will punch you. Accept that fear is here to stay. Anxiety is here to stay. And it's actually good, okay? Accepting is not resignation. It's not giving up. Be intentional. Get rid of what if. How many times have you said, what if my scans don't come back right? What if he comes into the consult room and says this? What if? Get rid of it. Anything that you can do to ground yourself, whether it is looking around and naming out loud or in your head what you see, hear, smell, feel. There's some breathing exercises that actually work better than benzodiazepines like Valium and Ativan, and they take about 45 seconds. I'm happy to provide some handouts for AIM to put on their website. And distract. Lastly, self-compassion. Give yourself some care. There's some great resources with Dr. Kristen Neff. Selfcompassion.org talks a lot about this. And the best part, this works so good, but you have to do it. Set an alarm every day to worry. 15 minutes. You do nothing else. I don't care if you scream, punch a pillow, take a walk, write about it, talk about it. I don't care what you do, but when that alarm goes off, you're done. And later on, when that worry comes back, you go, sorry, worry, sorry, fear. See you tomorrow at 10 a.m. Sounds so simple, but it works. And make sure you're asking the right questions of your care team. Don't walk in there with just random questions coming out of your brain at that moment. Plan ahead, ask the questions that you need to help give you that foundation to manage the fear when it comes. And then mindfulness is a huge thing. You hear a lot about it right now. I am not a yoga person that's going to sit in the lotus position by any means. My brain works not like that. I'm too spastic. So I'm talking about just sitting there and breathing, or putting on a short 2-minute guided something on your phone or on your computer. And here are some resources. There's another resource I want to mention really quick before I'm done. My mentor, who I meet with weekly, is part of their team over at MD Anderson in Houston. And honestly, very much a role model. He's a melanoma survivor, actually. He was very blessed with a third clinical trial and is teaching today. However, at one point when he was diagnosed, he decided that he was great at teaching us, other providers, and realized that he did not do very much for the patients. So he and his wife started a nonprofit called Anti-Cancer Living, and they have a short little book, kind of their philosophy. So Anti-Cancer Living, look it up. Then all of us, as a part of the Integrative Oncology Society, many of them got together, created another nonprofit, and it's all free to you. And it expands upon that initial work. And it's called Anti-Cancer Living. And there's free webinars, there's ebooks, it has everything about change, mindset, has everything about lifestyle changes for cancer survivorship. She'll go into this a little more. So at this point, I'm going to hand off to, I just have to get all your credentials. Lillian Swadek. She has been here as long as I have, and she is a registered dietitian, and she's going to talk a little bit about the nutrition for survivorship and also during your journey of treatment. Thank you.
Thank you. Thank you, everybody, and thank you for being here with us today. I'm Lillian Swatek, and I'm one of the clinical dietitians here in the Cancer Center. So I see a lot of patients undergoing treatment, but I do also see patients once they're done with treatment and have any kind of nutrition issues. Let me make sure this goes okay. Sorry. No, that's quite all right, quite all right. Okay, so what I would really want to talk about today is what can we do to strengthen our bodies so that our own bodies can help with that cancer fight. And we talk a lot about immune system, right? So there's things we can do in our lifestyle practices, in nutrition and exercise, that can help strengthen our own immune system so it can help us fight and resist that cancer. So that's where the benefits of plant-based diets come in. Doesn't mean you have to be a vegan, but eating more plant foods. I read a statistic one time that I was kind of sad about. 45% of Americans don't even get one serving of fruit or vegetable on a daily, regular basis. So, as a dietitian, to me, that makes me really sad. So what is it in a plant-based diet especially that can really help us out? And researchers, I think it was in the 1990s, where they found the first what they call phytochemical. Okay, phytochemical is a chemical in plants that help our cells resist cancer. I think the first one that they found was sulforaphane in broccoli, if I remember correctly. So what do these phytochemicals do? Well, they can reduce oxidation and inflammation in the body, okay, because that is something that may promote cancer. Slow cancer growth, help trigger the death of damaged cells, okay, help regulate hormones,
help block the ability of cancer-causing agents, which we call carcinogens, to be formed in the body. It can stimulate our immune system and prevent DNA damage and help repair DNA. Okay. And what we found with these plant chemicals too, or actually here are some examples before I get into that. Lignans is one phytochemical, and there's actually hundreds, if not thousands, of these things that are in our plant foods. Lignans is one example that we get in flaxseed. Lycopenes, maybe you've heard about that one with tomatoes, and you especially get a good concentrated dose if you like to use tomato sauce. That's been implicated in reducing risk for even prostate cancer, for instance. Limonoids in tangerines and other citrus fruit. Phytates that we get in wheat germ and whole grain products. And there's the one broccoli that I mentioned, the sulforaphane. And what they found with these phytochemicals is that if you have a variety of them together, they amplify the cancer protection. So they found that when you take the lycopene from your tomatoes and the sulforaphane from your broccoli and eat broccoli in, let's say, with some tomato sauce or with tomatoes in a salad, you actually increase that cancer fighting potential of those phytochemicals. So eating a variety of things, one food's not going to do it. Okay, so that's why I have this beautiful picture here with all these wonderful colors. You've probably heard about eating the rainbow. That's why we say that. Okay, the more variety, the better. So, you know, if you're going to have a salad and yeah, you have some iceberg lettuce with some dressing and maybe a sprinkle of tomatoes, try to make it where you have more vegetables in that salad. Getting a good variety of things is always going to be more beneficial. So you could see here, cruciferous vegetables have some good ingredients in them. Actually, all plant foods have these good phytochemicals that can help our bodies. Okay, gourds, squash, butternut squash, cantaloupe, zucchini. I'm not going to name them all. You can see them all here. Okay, the more variety, the better. Okay, now I did have one person one time, I'll never forget this as a consult. She came to me because she wanted to eat healthier and she wanted to lose weight. And the first thing she said to me, well, I got to tell you right off the bat, I'm allergic to every single fruit and vegetable out there. What do you do with that? So I don't know. I think I said, well, can we get some whole grains in you at least? Maybe you'll get some good plant chemicals that way. Really, the benefit you get from eating the whole plant food is much more than you would get in a supplement. For instance, they looked at vitamin E, okay, and using supplements of vitamin E to see if that made a difference in our risk for cancer. It didn't do so well, but getting the vitamin E in, let's say, toasted wheat germ or whole grain products was much more powerful. So getting these things in a powdered supplement really aren't going to be maybe for that lady who eats no fruits or vegetables. Maybe if she can tolerate a fruit and vegetable powdered supplement might be good, but really you get the most benefit from eating the whole plant food itself. And again, the greater variety, the better. Whole grains have those good phytochemicals in them too. And yes, whole grains do have carbohydrates in them. Our body needs carbohydrates to fuel our muscles. But unfortunately, Western diet has too many refined carbohydrates. Refined meaning that they strip out all those good fiber parts of the plant foods. So our diet consists of way too much ultra processed food with a lot of white sugar, white flour. So I always encourage getting things that are 100% whole wheat. If you get a bread loaf and the first ingredient says 100% whole wheat, that means most of the product is made with that whole grain. If the first ingredient says wheat and then says whole grain, it means that first ingredient is going to be most of that product. So whenever you can get any kind of grain products with 100% whole wheat as the first ingredient, you can get that with pastas if you want to increase your fiber intake that way. Whole wheat tortillas, barley, bulgur, oats, quinoa, brown rice, corn and popcorn, believe it or not, have really good plant chemicals in them too. I was surprised about the popcorn because I love popcorn. The only thing with popcorn is avoid the microwave bags. And, you know, popping your own with a little bit of oil is probably the healthiest way to do it. Oatmeal is a good way to get some plant chemicals in it too. Plants have developed these plant chemicals to give them some protection against the elements. I always like to use the example of a tomato plant. So you have this tomato growing on the vine. It's outside. It's in the sun 24, whatever amount of hours it is in the sun every day for days or weeks while it's growing. If we were to be out in the sun, as long as that tomato plant, what do you think would happen to us? We'd be sunburned to a crisp. But plants have developed these wonderful phytochemicals that, us by eating them, it confers us some of the benefit there. So let's look at protein. I'm talking about immune system. A lot of my patients, they're undergoing treatment if they're losing a lot of weight because they have side effects, poor appetite. I worry about them losing weight because that means they're probably losing some muscle mass. Okay, when we lose muscle mass, it actually hurts our immune system. It weakens our immune system. So especially going through treatment, protein needs can be higher. As we get older, our protein needs can get higher too. And yes, you can meet your protein needs with a vegan diet. It's just a lot harder to do. What we found out from the American Institute of Cancer Research, they look at research from all over the world, and they looked at, okay, if you have a plant-based diet that includes some animal foods, okay, is that worse than eating a straight vegan diet? Well, actually, they found there's benefits to both. So including animal foods in the diet is really okay, but I definitely encourage the healthier ones if you can. Skinless poultry, seafood that's not deep fried, low-fat dairy products, again, have lots of good vitamins, minerals, eggs, soy foods, nuts and nut butters, bean, peas, lentils, okay? Not only are you getting protein in these foods, you're getting healthy carbohydrates in some of them too. But anyways, going back to the protein. So if you're going through cancer treatment, try to include a protein source at every meal or snack if you can. The RDA for protein is about, I believe, 45 grams for women, 55 grams for men. But when you're going through cancer treatment, sometimes it could be doubled or even more. Even as we get older, in our older years, our protein needs can increase by 30 or more %. So it's important. I encourage you, if you're not a protein eater, if you can't get it through food sources, that's when I might suggest a protein drink, but I'd rather you get it from food whenever you can. So the protein sources that maybe aren't so great. The American Institute of Cancer Research, they have found that there is increased risk with eating more than 18 ounces per week of red meat, and that's beef, pork, and lamb. Okay, so you can have some red meat in the diet. It's really okay because it does give you a lot of good B vitamins, iron, good protein. Okay, so if we look at, okay, how much do you have for a meal? 3 or 4 ounces a meal. You're able to, eat maybe 3 to 4 portions like that in a week. So mix it up with your protein sources. I just get worried when somebody eats red meat twice a day for lunch and both dinner. So if we can mix it up with more chicken, fish, turkey, other sources of protein. Processed meats, they actually found that there is no safe level of eating processed meats. And that's things like bologna, salami, lunch meats, hot dogs. Okay, bacon is such a favorite one. Okay, now it doesn't mean you can't ever eat bacon. Because usually when I say that, it's like, huh? Doesn't mean you can't eat bacon. I just encourage patients not to eat it on a very regular basis. Okay, save it for a treat, save it for going out to eat with your family, maybe for a breakfast one day or Christmas morning. I think that's the one time a year that I might make bacon because everybody wants it. Okay, so it doesn't mean you can't have these foods, but please don't make them a regular part of your diet. Okay, and there are ingredients in processed meats, the way that it's cooked, there's all kinds of things, and they can produce what are called carcinogens. Remember, we talked about that before. So if you are going to eat some bacon, it'd be great if you can eat some fruit and vegetable with it. It might offer you a little bit of protection. And let's talk about grilling. They actually found that your cancer risk does increase the more char-grilled meats that you eat. Any animal protein, whether it's fish, chicken, turkey, beef, pork, lamb, if you char it, cook it at high temperatures, basically burning it, okay? A lot of times people love that char flavor that's on meat. Unfortunately, it produces cancer-causing agents that your body has to deal with, okay? So try to, there's some things you could do to reduce the production of those carcinogens when you grill meat. And we're not just talking outside on the grill, open flame, we're even talking about charring meat in a pan. So being careful not to do that. So some things you could do is marinate your meats for, a good 30 minutes before you put them on the grill or in the grill pan. Okay, that will help reduce the production of these carcinogens. You could see the long names, polycyclic aromatic hydrocarbons or heterocyclic amines. I never remember that. I always have to read it. But anyway, just so you know, cancer-causing agents. The other thing that you can do is maybe a little bit different cooking, use a piece of foil, maybe flip the meat more often so you don't get so much on that open flame. Cut the meat up in smaller pieces so you're not on that, open flame for longer periods of time. Okay, so there's definitely things that you can do if you like to grill outside. Smoked meats do have higher risk for cancer too. It does produce some of these chemicals. Okay. So again, your best bet is your fresh meat. So for instance, I'd rather you eat maybe a pork roast that you baked in the oven rather than getting ham, okay, because that's much more processed. As far as what an ideal plate looks like, okay, I remember growing up where the meat was like the main focus of the meal, okay. When we asked, well, what's for dinner? It was always like, okay, we're gonna have chicken, or we're gonna have beef, or we're gonna have this, this, and this. So usually it's half a plate full of meat and maybe some starch like, potatoes, rice, noodles, again, things that are pretty refined. Okay, that was you, and then maybe a little bit of vegetable on the side. Okay, but we need to change our thinking about that. Really, most of our diet should come from those plant foods. At least half your plate, should have vegetables or some maybe combination of fruit and vegetables. A third of our plate can be those good carbohydrates. We need some of those, but make them whole grain, make it brown rice, make it whole wheat pasta, make it a small baked potato or some sweet potato slices. Okay, and then the other fourth of your plate could be for your meat portion. Okay, and again, fresh meat is better, less red meat. And don't forget about beans and legumes, nuts and seeds. Those are good foods that have plenty of fiber in them. Fiber has been shown to reduce risk of recurrence, let's say for breast cancer. Fiber helps cling to bits of estrogen, so you get rid of it, and that it may confer some benefit that way. We don't know if they do that for melanoma, but all my recommendations here for overall reduction of cancer risk. Let's talk about sugar, because I get so many questions on that. What about sugar? I get a lot of people asking me that question. Will the sugar feed cancer? Has everybody heard that question? I get that so much. Well, guess what? Sugar does feed cancer, but it feeds every cell in our body. Okay. Whenever you eat food, you produce blood sugar. Okay. And that sugar feeds every cell in your body. So if you were to take away all sugar and even all carbohydrate, guess what? You'd still have blood sugar in your body feeding all the cells in your body. You have to have sugar in your blood. It never goes down to zero. But what they found with sugars, especially added sugars, is we can really overdo them. It's big excursions of sugar that can cause problems. Let's say you're drinking lots of soda and that's your main beverage all day, and you're having these excursions of sugar all day long. Well, guess what your body has to do to handle that and to keep your blood sugar under control? It has to give off large amounts of insulin, okay, to keep those blood sugars under control. And they found that having high levels of insulin might help cancer grow. It doesn't cause the cancer, but it might help that cancer grow a little bit better. Okay, so you do not have to avoid all sweets. Okay, but I do encourage you to avoid sweetened beverages. That's when we get especially large excursions, of those sugars and carbs. Okay, so try to stay away from regular sodas, juice drinks. I mean, it's fine to have a glass of juice. Maybe you like orange juice, but keep your juice intake maybe to about 8 ounces per day. That's plenty. And make water or other unsweetened beverages your main beverages throughout the day. As far as how much sugar, ideally less than 25 grams of added sugar per day. Okay, so now in the nutrition label, they actually put that on there, the added sugar, not the naturally occurring. If something has fruit in it, it's going to have some naturally occurring sugar, but what is the amount that they add to it? And you can see 1 can of soda already bypasses that whole recommendation right there. Okay, 1, sweet treat, maybe it's a scoop of ice cream, a piece of pie, that could be anywhere from 15 to 30 grams of added sugar. So you can have some sweet treats. We have the holidays coming up. I don't want to be that dietitian that says, no, you can't have any pumpkin pie. It's perfectly fine to have some sweet treats. Just don't make it a major portion of your meal. Make sure you're eating plenty of other good things with it, and having a sweet treat is really okay. I do have to mention a little bit on artificial sweeteners. They haven't found a significant or strong evidence to link artificial sweeteners with cancer risk. However, there has been some evidence that these artificial sweeteners eaten in large amounts can increase insulin resistance, which isn't a good thing. It might kind of keep you hooked to your sweet tooth, which may not be a good thing either. So there's other things that maybe aren't so good about eating artificial sweeteners. I'd rather a person, have small amounts of regular sugar, or use stevia in the raw or monk fruit extract Those are plant-based sweeteners that don't raise blood sugar. So if you like to, have something else to use, those would be good ones. And then alcohol. Alcohol has been shown to be a carcinogen. We used to think alcohol was good for the heart, and maybe there is some slight benefit with that, but we found that it does increase cancer risk across the board. So if you are going to drink, you really shouldn't have more than one a day, and even that may be too much with certain cancers. So yeah, no more than one a day for women, 2 a day for men, okay? Because they definitely increase cancer risk. Having a healthy weight, they found that obesity, being overweight, definitely increases the risk for cancer. So especially after treatment, not gaining weight is what I usually tell patients. If we can at least not have you gain weight, because that's been, that can increase your risk of recurrence and overall increase your risk for cancer. Exercise has been shown to fight cancer too. So recommendation is 150 minutes a week of some kind of physical activity. So that can actually fight. And remember that exercise helps maintain your muscle mass. Okay. So one of the things that I tell patients, even in treatment, if you're able to do any little bits of activity, that can just help you hold on to that muscle mass. But especially after treatment, getting into doing regular physical activity is one way you can reduce the chance of that cancer risk. These are my references here. So if you want to look up more information about cancer and nutrition, these are some good websites to go to. All righty. Well, thank you so much, everybody. And Anne will finish this up for us. Thank you. More questions.
Thank you. Thank you to our panelists. What wonderful presentations today. I will tell you that the sure sign that our audience has been engaged and listening and the presentations have been fabulous is a plethora of questions. And we have, they're just streaming in. One thing that we haven't done is make sure that everyone who took the time to be with us today, that your questions got answered. And so if you have questions, I have my trusty volunteers in the back. And if you'll write them down and raise your hand, we're going to make sure that they get up here to Dr. Gimbel and our panelists. Okay. I'll reintroduce myself. Here we go. Oops. There we go. I'm Ann Garst-Taylor. I'm with AIM at Melanoma. I'm their Director of Community Engagement. And I thank you for just a moment for the opportunity for me to tell you a little bit about our foundation. If you don't know our origins, 20 years ago, Val Guild founded AIM at Melanoma after her beautiful daughter, Charlie, was diagnosed at the age of 26 with melanoma and subsequently passed away. And it became Val's lifelong goal to find a cure for melanoma. And that was the first and foremost mission of our organization. And to do that, we have founded 6 tissue banks across the country, and we are trying to collect primary tissue for the purpose of handing that then over to researchers. And we are hoping that will continue to advance melanoma research. But in the meantime, we need to support people who are living with melanoma. And what does that mean for AIM at Melanoma? Well, we believe that well-educated patients make better advocates for themselves. They make better treatment choices. And we don't want you to have to go shopping for information on Dr. Google. We want you to be able to come someplace where you feel that the information is relevant and current and accurate. And so we've developed a wonderful website. It is so full of information. I couldn't possibly talk to you about everything that is on there today, but I want to talk to you about some of the things that you're going to find on our website. We know that our most visited web pages are on the stages of melanoma and the relevant treatment. We also know that people are interested in side effects and management of those side effects. We have wonderful, wonderful information on there. If you're not a person who reads to learn, we have Melanoma 101 videos. What does it mean to be BRAF positive? So I encourage you to come and look at some of those videos that we have put up. In addition to that, we have a melanoma clinical trial matching service. In fact, we have a whole new section of our website dedicated to clinical trials. Has a clinical trial been suggested to you? Are you thinking about being a part of a clinical trial? Well, then you can come to our website now and look and learn, what does it mean? What do who do you talk to about it? Those kinds of things. We have a program called Ask a Medical Expert, which Dr. Gimbel already spoke about. Melissa Wilson works in Pennsylvania as a PA in oncology clinic, and she has offered to answer questions that patients have about their treatment. Now, she does not answer questions about changing your plan of care. That's between you and your care team. But what she wants to do is help you to understand, why is your care team perhaps offering one solution versus another? What does your pathology report mean? Or what does it mean to be BRAF positive? And then what she did was create a number of videos based upon those most frequently asked questions. And they're called From the Clinic to the Living Room. And they're wonderful. And I encourage you to take a look at some of those videos that she has made. And perhaps you have a question that she can answer for you. Another form of education, of course, are these symposiums. We co-host 10 a year all across the country. What we will do at the end of this symposium is we'll take all the presentations, divide them by topic, and edit them so that they're streamlined, and we'll put them back we'll archive them onto our website. We've already gotten a number of questions from people, but I want to hear, what Dr. Szabo said. Again, well, you can do that. Immediately following this seminar, the symposium in its entirety will be available on YouTube and Facebook Live for some period of time. Then later, about 2 to 3 weeks later, they will be divided by topic and put on our website, and then you can watch the ones that you're most interested in. And lastly, I want to talk about our podcast. We have a podcast that's called Beyond the Clinic, and it's hosted by Ray Liu, who is an oncologist from Kaiser Permanente. What we talk about on Beyond the Clinic are the kinds of things that you don't typically address when you are in, your very precious time with your oncologist, right? But they could be things like fear of recurrence. It could be things about diet. And so those are the topics, or those myriads of ways in which cancer is impacting your life. And so we have a podcast, and that podcast runs once a month. And I encourage you to take a look at some of those topics and see if they might be of interest to you. The last thing that I want to talk to you about is Peer Connect. We have a one-on-one peer support program. We have a number of volunteers. These are individuals who have gone through a full treatment, and they are now stable, and they are ready to support people who are newly diagnosed. They are not going to offer clinical support. They're going to offer emotional support. Many people who discovered that they have melanoma, even though they might have a circle around them that is as supportive as they can be, they can still feel isolated. They still feel like that people don't really understand what they're feeling. And so being connected with someone who understands that, who can normalize that for you, and also who could say to you that you're living now. And we, what can you do to make sure that your life is full of normalcy and joy as possible? And so I encourage you, if you would like to have a mentor, to please get in touch with me. I want you to know that our mentors are not only patients who have completed that treatment journey, but they have gone through a training course. We have quarterly in-services, so we just get better and better at what we do. So I want you to feel confident that the advice that you're going to get is advice that we really feel like is going to make a difference for you. So here's what I want to move here and say, for those of you who are online with us, my trusty volunteer is going to put up our website address as well as my email address. Please feel free to give me a call. I'm there for you. I live on the eastern half of the United States. I answer my phone from 9 in the morning till 7 o'clock at night. You are welcome to call me. In addition to that, you can text me anytime. AIM is here for you. If you are here with us today, I put a little bookmark inside of your patient packet. There's a QR code there. We're QR coding everything. And this will take you directly to our website. Put that up on your refrigerator and come check out our website. Okay, we need to get to these questions so we can go home today. And so I am going to thank our panelists again. Thank, Banner MD Anderson Cancer Center. Thank you for being here. And I'm passing the baton back to Dr. Kimball.
Do you want to come up there?
Yeah, so let's do that. How don't I call you up? I guess we could have you come up, or sure, come on up. Yeah. Make it a little bit easier just to get up. And this is actually this question and answer is for all of our panelists now. So not just going to limit it. We're still getting questions about some treatments, and then there's a lot of questions about nutrition and some about support. So Dr. Szabo, I'm going to start with you. This one I think is about a caregiver question. And I know that's a big issue for a lot of our patients, or at least the caregivers for the patients. I think that's probably a whole talk in and of itself. But this is, my child has advanced melanoma. I don't worry for myself, but I feel helpless. What can I do?
So that's a big one. One of the things I'm most worried about when I have a patient in my office is the care team, because the stress of not wanting to burden your daughter, for example, or your loved one, not wanting to share your feelings of concern because they're already having their own. As far as a daughter, and I'm not sure of the age, so it's hard to speak to, obviously, but being open to discussing some of the psychosocial issues that come with the diagnosis and the survivorship. I'll give you an example. One of my current patients is in college, doing great, took some time off for treatment, but she has a hard time talking with family members because she's alive. So talking about her fear with friends or with her family members, or talking about anything related to it, she almost has this shame to bring it up because, boy, I should just be lucky. People have it worse than me, and I'm alive. So I shouldn't be complaining. I shouldn't have these fears. I shouldn't have these worries and thoughts. So just being very open and not avoiding the topic is what I would really express. And if you're in a cancer center that has psycho-oncology, go in and have a family session. If you can't instigate it because of the dynamics of a relationship, that's what we do. We put the hard things on the table and, push through them as a team. So thanks.
Thank you. And I know that I treat a lot of patients, and sometimes it's hard for patients to come to terms with a cancer diagnosis. Patients come in angry, patients come in scared, and me referring to Dr. Szabo and her team provides, I think, my patients a lot of solace, and I think they get so much out of it. So it's probably underutilized for us as clinicians, but I think we need to remember that that's a very important part of what we can offer here. All right, a lot of nutrition questions, so they'll in where I'll throw a couple of these out. I'm going to give you a couple cards, and maybe you can read this. But let me ask a couple of questions I wanted to touch first. And so, someone has cancer already. Can they have a drink during cancer treatments? I get this question a lot. Can I have a glass of wine if I'm getting treatment? Is alcohol detrimental if it calms my nerves? Can I use that as instead of another type of drug? And then, why don't you answer for alcohol? Because alcohol.
You were going to help me.
No, that's
Well, usually what I say is get permission from your doctor to be able to take that alcoholic beverage. I guess my feeling on that is my nutrition recommendations during treatment are often very different to what they are once you're done with treatment and can eat normally. Because if a person is eating, let's say, really poorly during treatment, they're losing weight, they're losing muscle mass, I'm going to be just happy that they're eating, eating something. And so, if that drink helps them maybe improve their appetite, that might be okay. So kind of there's a difference there. Is it, reducing the risk of cancer recurrence after you're done with treatment, or is it during treatment and maybe you're really eating poorly and losing a lot of weight? My nutrition recommendations are going to be a little different. Another thing on alcohol is alcohol can upset the stomach. Okay, it is something that can do that. So I'm just a little concerned about that. I usually say, well, if you're going to have a drink, maybe have food with it so it doesn't upset your stomach as much. Keep it to one drink, as I showed before. That's usually the recommendation. And again, checking with the doctor to make sure there are no contraindications, maybe with medications or other things. Thank you.
Go ahead.
Okay. So I guess the second half of that question, thank you. The second half of the question is someone who's using alcohol during treatment to calm nerves. We know everyone has that. Not everyone. A lot of people like that glass of wine at night to calm their nerves. Is that the right way that a patient should be trying to get that sedation a little bit, or should there be other? Is it detrimental? I guess is the question, Dr. Szabo, if you can.
Well, I'm an 80-20 person, whether you have cancer or not. I feel like everything in moderation. However, I can tell you many people don't even like the taste of alcohol during their treatment. And if you do like a specific drink, a margarita or a glass of wine, and you have an off taste in your mouth or an off olfactory system where things don't smell right, I would caution you from tasting, eating, or drinking anything you love, because you will not love it afterwards. So use your own olfactory system and sense of taste to guide you there. Again, also some of the interactions with the alcohol and some of the medications are really important to consider. So again, going back to your physician or even to your pharmacist to say, what are the interactions of this before you make that jump? But I tend to go along with Lillian in saying that if all things aside, and it's going to help a little bit, but also realize, you're in a place where self-medicating becomes very easy, right? We're putting a lot of pharmacology into your system. Is there a need for more? I mean, that's kind of a question you need. Maybe once you get all of those other drugs out of your system, maybe that's the time. So I think it's an individual situation for sure.
All right. I have a question here. Do sugar alternatives spike blood sugar? Well, the artificial sweeteners, as well as the stevia I mentioned, monk fruit, they do not raise blood sugar. And that's why they often use them in diabetic products, sugar-free products. So don't worry about your blood sugar with those. Should I keep going with all of mine? Okay. Are impossible vegan sausages considered processed meat and therefore to limit? Actually, no, you can use those vegan substitutes. In fact, I found a really good hot dog substitute for anybody that's interested. It's called Field Roast Frankfurters. I can only find them at Safeway. And they have 25 grams of protein, but they are made from vital wheat gluten. So as long as you don't have a gluten intolerance, they're a wonderful substitute for animal hot dogs, if you like to do that. Relationship between microbiome and response to immunotherapy. Well, I mentioned about the immune system. One of the things that can keep our immune system strong is to have that good gut bacteria. That actually is very related to our immune system. And so eating those plant foods, which are basically prebiotics, help feed those good bacteria, and that can help strengthen our immune system too. What suggestions do you have nutritionally for patients who have daily diarrhea after starting immunotherapy? As far as food goes, if a person's having a lot of diarrhea, I usually want them to kind of limit their fiber, especially insoluble fiber, like skins, nuts, seeds, bran, okay, raw vegetables and fruit skins, because that might contribute to the diarrhea. It doesn't cause it, it just might make it worse. Lactose, milk sugar sometimes gets harder to digest if you're having a lot of diarrhea. So using, non-dairy milk substitutes or lactate milk might be helpful during that. And eating foods that might help slow the diarrhea. Believe it or not, like, usually I say eat the high fiber stuff, but during diarrhea, things like white pasta, white rice, mashed potatoes, eating those oatmeal, those things might actually help slow the diarrhea some. And then, of course, talk to your doctor or nurse about over-the-counter medications that may be helpful for that. And then this one, please address studies on peanut butter and spread of cancer. I don't remember any studies on that. I will have to do some research on my own. The only thing I could think of on that is I know that if you have shelled peanuts, you know, the kind that you have to take the shells off yourself, I know that there can be maybe spores and molds that can be in there. I'm not quite sure if that's what it's related to, but I have not seen any good evidence saying that eating peanut butter or eating nuts. In fact, the type of fat that's in nuts is one of the healthy fats, and the fiber you get in nuts has actually got some good plant chemicals. So I guess I'm going to have to do a little more research on my own to find if there's any link to that. And that was all of mine. Thank you.
I'm just going to make a quick change really quick. Take this down. Oh, we'll leave it if we do that. Never mind. Yeah.
Just keep that. All right, perfect.
There you go.
All right, Dr. Abbott, what sunscreens should we be wearing, and does the brand of the sunscreen matter? Give her a second to walk up here. So for those online, I know this, everybody wants to know how much SPF we should use.
I love sunscreen questions. So I think there's a lot of talk about sunscreen, and people can get really caught up on which type of sunscreen you're using. There's chemical versus physical sunscreens, or people call them natural and organic and inorganic. So there's a lot to get caught up on, but the best type of sunscreen is the one that you're actually going to use. So the one that you'll actually apply to your skin. You know, patients want to have these conversations, and if I recommend a certain cream to them, but they don't like the way it feels, they're not going to use it. So you want to use the one that you'll actually apply. So I would say that's your first criteria. And if you can find one that you'll apply, then maybe start branching out and trying other ones. People do sometimes recommend the mineral sunscreens over the chemical sunscreens, but I will say there is more information coming out about the chemical sunscreens, and I think there's less fear surrounding those now than there previously was. And so the best sunscreen is the one you'll use.
So this question asks about head and neck melanoma versus other sites of the body. Is head and neck melanoma more aggressive than elsewhere? This is not a straightforward question. The reason being is the head and neck has a much more robust lymphatic drainage. Someone who has a melanoma on their scalp, it could drain to occipital nodes, it could drain to periauricular nodes, it could even drain down to the neck node. So there's a much more robust lymphatic drainage, which makes finding that sentinel lymph node, if it's early stage melanoma, also much more challenging. And because it is more enriched, there can be a higher risk of spread, but we still base the risk of spread at this time on depth of tumor into the skin. So a tumor that's deep into the arm skin versus a tumor that's deep into the scalp skin, stage for stage should have the same risk. When we look at the pathology report, there's something called Clark's depth and Breslow's depth. Breslow's depth is actually a measurement of how deep into the skin it is. Clark's depth is actually what layer. There's 5 layers of the skin, and what layer of the skin has it gone down to? And so the scalp has much thinner layers, so it's easy to get tumors to go down into the deeper layers of the skin than, say, on the back where the skin is really thick. All right, this is kind of a nuanced question here, but how do you know, Dr. Mahmood, if you're on treatment, how do you know if when your tumors get bigger, this is pseudo-progression or progression of the actual cancer?
That is an excellent question. I treat people with stage 4 melanoma, and how can we differentiate between pseudo progression or really actual progression of the tumor? I mean, if we look at the clinical, the patient, is he healthy? Is he doing fine? Is he losing weight or not? If the person, I mean, sometimes I open the door, I look at them, they're pale, they're weak, they're no energy, and they're losing weight. I look at the chart, there's a lot of, weight has been lost. I'm thinking more like, I'm really concerned, that this could be a real progression. But if the person is healthy and said, like, I've used to have this pain, I'm not having the pain, and the weight is good and they're feeling good and no symptoms, I may continue on treatment. Because, once we start with immunotherapy for stage 4, I mean, we can't make a decision based on a 3-month scans. So 3-month scans could show this pseudo progression. If they are doing well, we continue and we do scans in about 6 months. And that scan usually within 6 months can tell us the real story. Are they having real progression, or are they having just, pseudo progression? And when I'm in doubt, I always do a biopsy.
And I think your answer leads nicely into this next question. Says, how often do you recommend PET scan, MRI, CT scans? How often should we be scanning people when they have melanoma? And I would offer that it depends. Depends on your stage of cancer. If somebody has stage 4 melanoma, we're going to be following you much more closely to see how the disease is responding or if it's still spreading. So we're going to want to know that more often. If somebody has stage 3, we're going to scan less, and it depends on, and at stage 2 and stage 1, it really depends on that risk of recurrence. So risk of recurrence is, I use the genomic expression profiling test to determine that risk. And if someone's at high risk, I may scan every 4 months. If I find someone's low risk, I may never get a scan. So I think that question has a lot of nuances to it, but essentially it's going to be on the stage of your tumor, the treatments you're on. If you're past treatment, maybe it's an annual scan. So hard to really peg that question down, but it depends. I'll leave this one to our last question because that's a good one. If taking targeted therapy, and I'm not sure if you're going to know this. So someone asked, does sugar have to be avoided? I think that's a pretty nuanced question, and I don't know if there's direct answer to that, but I think maybe it's just sugar. You touched on sugar during treatment. So I don't think the actual treatment matters. Any insight into that in terms of what someone's getting? Do some treatments make hyperglycemia worse?
Steroids can make hyperglycemia worse, can raise your blood sugars. As far as other treatments go, I believe there's one called Piqray for breast cancer that can cause high blood sugars. Some of the immunotherapies may cause, I've actually had some patients actually get diabetes. But still, even with any of that, it doesn't mean you have to take out every single grain of sugar. You just have to manage how much, how often that you have to help manage those blood sugars. So again, you don't have to be on a 0 sugar diet. That might not necessarily be the most beneficial thing.
Dr. Szabo, can I get you to answer that? Yeah. This is a great question. So the question for Dr. Szabo is, who should be on my care team? Who do I involve with that? I think that's it.
And that's a great question. You need one. You need one that you can trust and that can advocate for you, that can be forthright with you when they feel like you're going down a rabbit hole. Would it be great to have an entire village? Absolutely. But one, for some of my patients, our patients, they have none. And so it's really intentionally finding that one person that you can connect with. And sometimes we see it happening in the waiting room where all of a sudden there's a connection between patients. But definitely for survivorship, at least one, as long as the people, no matter the number, are trustworthy and understand what it's like to be a survivor. Even if you are living, you still have these different thoughts and a different paradigm. And they need to be able to understand that you're a different person, no matter what, and honor that. And that's pretty much what we would all want, right?
Great, thank you. All right, Dr. Mahmood. I'm going to extrapolate a little bit. So this is a patient who is on immunotherapy. They don't have a BRAF mutation, and immunotherapy is not working. What are some other options for patients?
Yeah, the BRAF unmutated or the wild type metastatic melanoma, the standard of care is to give immunotherapy, but unfortunately, if the immunotherapy doesn't work, we don't have any FDA approved agents, but we just mentioned about the TIL therapy. So the TIL therapy, meaning you go to a TIL center where they can remove the melanoma and, they can identify those immune cells that they are active against a tumor, but unfortunately your tumor don't have enough of those immune cells. So they extract them, they put them in the lab, they give them some food, high dose IL-2, they grow them to millions and then give it back to you. And that has been shown to result in a 35% response rate, even if you failed immunotherapy. So that would be a great option. But again, you need to really be fit for this treatment. And I think you have to follow up with your oncologist or the center that you're going to do the TIL therapy, and they can, advise you whether you're going to be fit for the treatment or not. If you are not, then you have to look for a clinical trial.
And I think with melanoma and what we've seen over the past 5 years is that the new treatments that we now have at our fingertips are accelerating. And there are a lot of trials that are out there. There are a lot of new ways to treat melanoma and stimulating the immune system that's out there. So don't give up hope if your treatments aren't working. I think there's other options out there. This one's asking about stage 2 melanoma. We touched a little bit on it, but someone has a stage 2A. So there's 2A, 2B, and 2C. Depends on the thickness of the tumor and how much cancer is in the lymph. Just the thickness of the tumor, excuse me. They've had it excised, a negative sentinel lymph node biopsy, so we know it's not in the lymph nodes. What about Keytruda? Could they get adjuvant immunotherapy? And there's no study that actually supports adjuvant immunotherapy for stage 2A. For stage 2B and stage 2C, adjuvant immunotherapy is now being recommended to reduce the risk of recurrence. Again, we know that immunotherapy does have side effects, and that's a discussion with Dr. Mahmood to decide, is it worth the risk of recurrence versus the potential side effects from treatment? We have to look at the patient as a whole. What are your other comorbidities? What are your other ailments that you have? Is this worthwhile? We also know that for stage 2C, when you have an ulcerated thick melanoma, actually has a worse outcome than somebody who has microscopic disease in a lymph node for stage 3A. And so these are patients we would definitely recommend adjuvant immunotherapy for the stage 2Cs. The 2Bs, the data is supporting to do it. I think this is one place where I use genomic profiling to see what's the biology of someone's tumor. Currently, that's not a standard recommendation, but I think if we're wavering on whether or not to treat somebody with adjuvant immunotherapy for stage 2B melanoma, I think that can be another piece of information, another tool in the belt that can be used to help make that decision. All right, I think we're getting to the end of our questions. So before we get to this last question, I do just want to say a couple last things. That for those people who attended or are here, you have a black ribbon in your bag. And if you haven't yet already been able to take your ribbon and put it on the tree of life downstairs, it's a nice touch to be able to put that ribbon and say, I got this. This cancer is under my control. This cancer is not controlling me. And it's a nice little statement. And our tree has grown and grown and grown downstairs. And it's a beautiful thing. And finally, I want to thank Kristen Lesniak and Sandra Stockton. Without them, this wouldn't be possible. You guys have made our program here what it is. You let us do these wonderful symposium. You're out in the communities. I think the patients know you. I think the providers know you. So thank you for the work that you do. And I guess I'm going to ask this to everybody. When can a patient say that they no longer have melanoma? So Dr. Abbott, Dr. Mahmood, why don't you go up and give an answer to what you think that means?
So I would say that it probably is best to say you don't have melanoma when you have completed your treatment and are found to be in remission. And so having that mindset, or even when you're starting on your treatment, is like the first day that you're starting to fight that melanoma. It's probably a good time to take that perspective, because as we heard earlier, so much of our perspective and attitude during cancer therapy does influence our treatment. Sorry.
So when I treat people with stage 4 melanoma, I use the word curative intent. And I get a lot, a lot of questions about it. Are you really curing melanoma? When it's now, for the first time, we are looking into the neoadjuvant treatment, and we are giving the neoadjuvant treatment, and we're getting this pathology report, and we're saying you have a pathologic complete response. We are able to look at the microenvironment, and we are able, with the pathology and evidence, to say there is no melanoma. So for me, I would not use palliative treatment. I would use curative intent. And I hope that when we have the long-term, data from these wonderful trials, which is, we have to wait 20 years, 30 years. Hopefully this data just stay solid and strong, and those people who derive benefit will continue to have a flat line for years and years to come. So for me, it's a curative intent.
Leave it to a medical oncologist to not really answer the question. As a surgeon, I say when I cut it out, you no longer have melanoma. I mean, completely on the other side. We always look at 5-year survivals and use that as a benchmark. Is there anything special about 5 years? I don't think so, but we know that the risk of recurrence decreases as time increases. Could you get a melanoma that recurs at 10 years? Absolutely. Are we going to worry about that? No, we're not. Usually after a couple of years, if your melanoma hasn't come back, the likelihood that this melanoma will come back is going to be really small, and we should assume that you're cured. Doesn't mean you can't get another melanoma. Your risk factors are still there. And one thing that I actually want to bring up really quickly, even while on treatment, you can still get another melanoma for patients who have advanced disease. We know that the epidermis, the immune milieu of the epidermis is actually not great. And so if you're using immunotherapy to ramp up the immune system to treat widespread melanoma, it doesn't really impact what happens in the epidermis and the mutations that you've already received. So patients still need to keep this multidisciplinary team, still need to see the dermatologist, still need to follow up with the medical oncologist. The surgeon is still involved. So we would continue that multidisciplinary approach. So when are you cured? Hopefully we can give you an answer to that. I would say, we'll keep working with you to make sure that it doesn't come back. So with that, I want to thank you all for being online and joining us here, for being in the room. We love doing this. It allows us to interact with people who we take care of on a daily basis. And we just enjoy having these interactions. So thank you for being here, and we'll talk to you soon.